Hey guys, am I audible and visible? If so, say me hi, hello, how are you doing? Sorry to disturb you on a Saturday and a weekend. I hope I'm audible and visible, right? Let me refresh it. Hi, Javed. Okay, thank you. Good evening, Kranti. Good evening, Javed. Hope you guys doing good. So this is we have initiated a PYQ session. I know that you have still more than a month left. We'll definitely do the marathon again. So we're close to exams. It's just to make sure that you are still in touch, not getting kind of deviated from your routine learning process, which is very very important, especially in the difficult times. Whoever sustains will definitely go to it, right? What's your PDF will definitely come after the session. These are just MCQs. I'm just going to use MCQs and I'm going to just give you how to think and answer them. All these are previous year questions only. I am not going to deviate anything from other than from the previous year questions. Fine. Um, Dr. Blocks, it will definitely be useful, this ones, because both of them are NBE based only. So I think you can attend this also. We'll have marathon for FMG, which will be announcing soon. Fine. Okay. So since these are completely PYQs, I want you guys to have a very active participation. Don't be relaxed. I want you to answer what is the correct answer. A, B, C, or D. Simple things, you can do it. And don't worry if it's wrong. Let it go wrong. We'll see how to analyze them. Not much of it, not much details into the topic. If you have any query, definitely I'll be able to answer it. Fine. Ashutosh should be enough because we are taking care of, at least me, I'm taking care of past 5 years. The topics. If there are overlapping topics on iron deficiency anemia in 2 years, I'm taking only one so that that topic remains relevant. That's all. Fine. Okay. Okay, guys, let's go. Read the question, comment on the answer. But Javeed, it is good if you are redoing, revising, not doing it for the first time. Fine. Renika, these are NEET PG PYQs primarily, but again, the topics might overlap for the INICT as well. Let's start. No more questions, only answers. Okay, Vivek has started the thing B. I want at least like 20, 30 responses flooding around so that everyone who's not answering also has to answer. Fine. Okay. Great, 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 great. Anna will do it for sure. We'll announce it very soon. Great, amazing. Fine, perfect. So I'm going to highlight the keywords. If the question is this big, the first issue is we'll get stumped like, should I read the entire question? Or it's very, very big for me, right? 38-year-old person complains of weakness, lethargy. This is not important for me because that's characteristic feature of every anemia. Heavy menstrual bleeding is a clue pointer here. Whenever I see of menstrual bleeding, what do you think is the diagnosis? Etiology is there, looking for a diagnosis. One thing, have a retrospective approach, especially when you have a long stem question. Right, that's very, very important. When the question is like 4-5 lines, read the options. Keep that in your immediate memory. With that options, read the question. Heavy menstrual bleeding, the first possibility for us is IDA, right? Anyone is going to think of an iron deficiency anemia, whereas in heavy menstrual bleeding. Peripheral smear shows, blood test shows small RBC with pallor. Small RBC rules this out, right? Small RBC, I won't say it rules of hypoplastic anemia. Hemolytic anemia also, let's keep at least to some extent, fine? Hemoglobin 7.9. MCV is reduced, MCH is reduced. I am not going to think of hypoplastic anemia because hypoplastic anemia will have pancytopenia. It will not have only anemia. That's one thing. Hypoplastic indirectly means aplastic anemia. Fine. TIBC is high, transferrin saturation is low. So Vivek said that high TIBC is an IDA, right? You are absolutely right. I'm not denying that at all. But I want a very logical approach to them so that you not memorize them, right? So there are 4 iron studies. I've told this before itself. Can anyone enumerate what are the 4 iron studies? Whatever comes to your mind. One is TIBC. The first obviously is serum iron, right? Then we have transferrin saturation. Then we have ferritin. Then we have TIBC, right? Total iron binding capacity, right? Perfect, Maro. Okay, perfect. So these are the 4 serum iron studies which are primarily involved or primarily worried about. There are multiple more, not going into that, right? Keep a very simple thing. Iron and saturation are directly proportional and ferritin and TABC are inversely proportional. Never ever forget this. This is not just for IDA, it's for anything where I want iron studies. Remember this. 30 seconds, your brain will beautifully follow it up and create a concept out of it. Fine. Now, what do you think will happen to serum iron in case of an IDA? In IDA, what will happen to serum iron? Not difficult, reduced. Directly proportional transferrin saturation, reduced. Serum ferritin is the most sensitive test. That also is a very old PYQ. Most sensitive test for an IDA. What will happen to ferritin levels in IDA? By default reduced. So what will happen to TIBC? By default elevated, because it's inversely proportional. That's all. Why I want you to remember directly inversely is, let's take one more common DD which comes in your PYQs, anemia of chronic disease, right? Again, before going into the serum profile, I want you guys to answer one example for anemia of chronic disease. In which disease you will see them? Any one example is enough. Anemia of chronic disease. Can I see in patient with tuberculosis? I can, right? Any chronic inflammation, rheumatoid arthritis, TB, I can see them, right? Perfect, amazing, right? CKD is different, Gayatri. CKD is anemia in CKD. CKD is different from chronic disease. Please don't confuse both of them, right? I have anemia and chronic kidney disease is different. Anemia and chronic disease is different, right? Perfect. Any chronic inflammation have. Any chronic inflammation, put a star mark here. I have to start with this because ferritin is an acute phase reactant which will be elevated in chronic inflammation, right? Perfect. If ferritin is elevated, TIBC is reduced. If ferritin is more, that's my stores are more. I am storing a lot of them. What will happen to free iron? Free iron will reduce. So what will happen to TSAT? TSAT will reduce. This is the practical comparison. You must have read about comparison for many diseases like thalassemia, like sideroblastic anemia. No one does iron profile for thalassemia. You know that for a fact, right? So this is how we compare them. Iron studies, if you want to read it before the exam, this is very important. I'll definitely give this PDF. Please read from this. That's all, fine. Priyadarshi, after the class, we'll definitely give that the Telegram link below, fine. Okay, next question. I want you guys to comment. Very simple. I'll keep quiet for 10 seconds. Come in. RDCing, what do you mean? This was 2024 PYQ. It's amazing, right? Perfect. So I want you guys to answer one thing. How many of you looked at this image and jumped into an answer? It's Hodgkin's lymphoma. Tell me honestly. If yes, comment yes or why. How many of you looked at the image and just jumped into Hodgkin's lymphoma? If yes, comment yes. Because you know this PYQ. You've been seen multiple times. That is a wrong mistake. Do not judge a question with an image. It could be a bait, right? That's where silly mistakes come from. I'm very happy it's outside. I'm very happy you know that is RSL. But still, patience, no? 45-year-old, okay. Fever, night sweats. These are the B symptoms. Itching, unintentional weight loss, most likely a malignant condition. Biopsy reveals, and there is an axillary lymphadenopathy. Now the confidence of me telling is Hodgkin's lymphoma is way higher, and I have a classical owl's eye appearance, right? Owl's eye appearance or a classical RSL. Definitely it's Hodgkin's. This you're not made a mistake, but please make sure that in an exam, don't jump like this. Silly mistakes come in the first 10 seconds of answering the question, not after that. 10 seconds. It will not take more than 10 seconds, right? It's not non-Hodgkin's lymphoma. It is definitely not non-Hodgkin's lymphoma. It's definitely not sarcoid. The only thing here is Hodgkin's lymphoma and ABVD regimen. You must have read about ABVD regimen in both your pharmacology and as well as your medicine. I'm not going to comment on that, right? So with respect to Hodgkin's lymphoma, there are few important topics which have been asked previously. I'm going to ask you the question and I want you to comment on the answer. What is the investigation of choice for Hodgkin's lymphoma? I'll give you two options. Biopsy or IHC or flow cytometry. What do you think? Hi Sindhu, good evening. Biopsy, IHC or flow cytometry. What do you think? It is biopsy plus IHC. Please do remember, just because the flow cytometry is a very new investigation doesn't mean that I'll be able to apply it for everything. Lymphoma is a solid malignancy. Flow cytometry will not help that much because the biopsy RSLs are very less in number, right? For Hodgkin's lymphoma, it is always biopsy plus immunohistochemistry. Flow will not help, right? Second question. For a patient with a classical Hodgkin's lymphoma, right? A classical Hodgkin's lymphoma, tell me the markers. And also a patient with NLPHL, tell me the markers. There are many markers. I just want you to remember what comes to your mind first. Classical Hodgkin's lymphoma, RSL, IHC markers and NLPHL, IHC markers. Hi Shivangi, hi Dhriti. It is 1530 for classical RSL and for NLPHL, it is 1530 negative and the most often sorted is 20 and 45, right? And obviously it's 1530 negative here, right? Great. One question, again, this is important for you. In which of these tumors PAX5 will be weakly positive, classical or NLPHL? The marker is PAX5 because PAX5 is being used more these days than my 1530 and NLPHL. BCL6, you are right. I'm just going with the key points, that's all. Fine. Classical will be weakly positive. Please remember that. NLPHL will be strongly positive. PAX5 is a B cell marker that also came once in an FMG exam. It's a B cell marker. Just remember that, right? If it's weakly positive, I think of an classical, and strongly positive, I think of an NLPHL, right? Great, amazing. Just one more thing. The Hodgkin's lymphoma with the best prognosis. Which variant of Hodgkin's lymphoma you think has the best prognosis? Prognosis best for Hodgkin's. Great. It is NLPHL has the best prognosis. Okay. Then we have your non-classical or NLPHL. Marrow sclerosis is amongst the classical Hodgkin's lymphoma. NLPHL is best. Apart from your, in classical Hodgkin's lymphoma, obviously you'll have nodular sclerosis. Fine. Okay, it's NLPHL first in classical Hodgkin's lymphoma by default in nodular sclerosis, right? If in total, I want it to write as NLPHL, right? Last but not the least, Hodgkin's does not end without asking this question. What is the RS cell which you see in case of an NLPHL? The name of the RS cell in case of an NLPHL, that's your RS cell. You must have seen all the classical popcorn variant of an RS cell. I hope they won't give you that in an image. It's very difficult to identify that. If they give, it's great. Fine. Perfect. Amazing. Okay, let's go to the next one. Ready for the next one? I want you guys to comment on the answer. Tell me what's the answer. I'll keep myself quiet for 10 seconds. Again, can we do a practice? Don't answer in the first 10 seconds. Look at the clock, 10 seconds after that answer. I think in 10 seconds, most of you are completed answering it, right? It's very simple. It's asbestosis, right? So what are these guys? These are your asbestos bodies or ferruginous bodies, right? Ideally, the term asbestos bodies and ferruginous bodies are not the same, but for every exam purpose, it has been considered as the same, right? So these dumbbell shaped structure, it might not look like a dumbbell, right? But it's classically mentioned as a dumbbell shaped structure, is your ferruginous body. Okay, perfect, great. You're told everything required for asbestosis. I need not, I don't think so. I need to ask them. The lobe, the prognosis, everything is there. Just let's read the question and let's see if there's any variation. What will be the question for silicosis? What might be the question for cold workers pneumoconiosis, right? A middle-aged person came with complaints of dyspnea, chest tightness, dry cough, found to have interstitial diffuse fibrosis. This might be the feature for almost every pneumoconiosis, right? Pneumoconiosis comes under fibrosing diseases of the lung. Any pneumoconiosis, be it cold workers, be it silicosis, clinically they'll present as interstitial fibrosis only. Lung biopsy is there classically present, right? Which of the following industries has been likely worked for the last 20 years? The answer is complete asbestos, right? Perfect. I'm not going to Kaplan syndrome, crazy doctor. They have ignored Kaplan. Let's not remind the NEET PG people about Kaplan and all these named syndromes. Let's learn medicine. Fine. Okay. Few clues. Tell me what will be the history or which place the person must have worked for coal workers pneumoconiosis. Coal workers pneumoconiosis by default mining, right? Okay. What is one microscopic finding you will see in patients with coal workers pneumoconiosis? If this is there, I'll say in microscopy, the slide is coal workers pneumoconiosis. What one finding? One finding. That finding is don't look at anything black color. Color. There's no other black pigment in my body. Your melanin is also brown. Black color, anthracotic pigment, be it in a hilar lymph node or in a lung biopsy, anthracosis or coal workers pneumoconiosis. That's all right. Can anyone tell me what type of pigment causes coal workers pneumoconiosis? If you remember asbestos, you must have read about your serpentine fibers and amphibole fibers. Like that I have for coal also. Which type of coal causes coal workers pneumoconiosis? Here type of coal causes And the name says you have an anthracite coal. Anthracite coal causes coal workers pneumoconiosis. There's one more type of coal. I'll write here bituminous coal. Bituminous coal does not cause coal workers pneumoconiosis. It causes lung cancer. Okay, we have two types of coal. Bituminous coal comes from burning firewood. It causes lung cancer. That does not cause coal workers pneumoconiosis, right? Second, silicosis. Which is the most common occupational lung disease? Is it coal workers pneumoconiosis or silicosis? The most common occupational lung disease is coal workers pneumoconiosis. The most common variant of anthracosis is not termed as occupational lung disease. You and me also will have anthracosis, right? Most common is by default silicosis. And what industry will they work? Glass blowers, glass manufacturers, anything related to glass. By default, silicosis should be the first finding, right? Silica involves upper lobe or the lower lobe of lungs. Though not great, which lobe of the lungs do they involve? Generally, they involve upper lobe of the lungs. Stone cutter, yes, obviously. Okay. And silicosis, there is one specific stain which is the diagnostic thing for silicosis. Like we have pearl stain for your anthracotic pigment, your asbestos. Silica particles are positively birefringent. Please remember them. If you have a lung pneumoconiosis with birefringent particles, keep it as silicosis. Since we are in birefringence, I'm going to ask two more questions, which is also important PYQs. Where do you see needle-shaped crystals? Negative birefringence. I want the answers coming like anything. Needle-shaped crystals, negative birefringence. Comment. Perfect. Next birefringence, apple green. Nitu, not pseudogout. Needle-shaped negative birefringence is gouty arthritis. Sodium urate crystals. Apple green is your amyloidosis, right? Perfect. These are the only three places a MBBS student should know regarding birefringence, right? Perfect, right? Next, third, asbestosis. Asbestosis, we have the serpentine fibers, we have the your amphibole fibers. Which is more pathogenic? Serpentine is more pathogenic or amphibole? Comment just yes or a, that's enough. The more pathogenic fibers or more damaging fibers for me is amphibole. Serpentine fibers are not that pathogenic, but they are more commonly used, right? Perfect. Again, one of the most sorted question, but recently they are not even bothering about that. What's the most common carcinoma related to asbestosis? Most common carcinoma related to asbestosis is lung adenocarcinoma, right? It's lung adenocarcinoma, fine. No, most common is not mesothelioma. Most common is lung adenocarcinoma. Please don't make mistakes on this. We have been repeating this many years. Specific tumor is mesothelioma. Most common undoubtedly is lung adenocarcinoma, not mesothelioma, right? And you guys already answered that Pearl's Prussian blue will be positive in case of an asbestos fiber, right? Perfect. So this is just what all pointers might be required the day before in an EPG exam. Just go through it, right? If something comes out of it, great. Okay. Next question. 10 seconds. Try not to answer. Let's see. We don't wait for 10 seconds, right? Crazy doctor, wait. Let others also answer. Okay. It's a very simple one, right? You can call it an ophthalmology question or you can call it a pathology question. 6 months person, leukocoria, cat's eye reflex, synaptophysin positive, NSE positive, chromogranin positive, shows palisade spoke wheel arrangement surrounding a central core. Identify the lesion, right? Answer is fine. Okay, perfect. Now, please tell me, what is this? Can anyone tell me what they are describing here? Shows palisade in a spoke and wheel arrangement surrounding a central core. Can anyone tell me what this is? That's your, I think Learn and Teach has answered that before. That's your Flexner Wintersteiner rosette. Okay. So instead of asking Flexner Wintersteiner rosette, I am explaining it. That's all. Okay. RRR. So Homer, right? You asked, open the Pandora box of where other or what are the other features where we see rosettes, right? There are 4 rosettes. We have Homerite rosettes. We have Flexner Wintersteiner rosettes. We have your true ependymal rosettes, and we have your Perivascular pseudo-rosettes. Let's go. Where do you see Homerate rosettes? You guys know this? You guys must have definitely read this. Where do you see Homerate rosettes? Homerate rosettes are seen in neuroblastoma. Homerate rosettes are also seen in medulloblastomas. Okay, neuroblastoma, medulloblastoma, we see Homerate rosettes, right? Perfect. Ewing's, I'm not considering it here. I'll come to Ewing's very soon. Okay, flex nerve intestinal rosettes, we see them in retinoblastoma, like our case. True rosettes, they are classically seen in ependymoma. Okay, perivascular pseudo-rosettes can also be seen in medulloblastoma, can be seen in neuroblastomas as well, can be seen in Ewing sarcoma also. The reason why I didn't put Ewing's in Homerite is Ewing's is very, very non-specific. Ewing's, yes, they can have Homerite. Yes, they can have perivascular. They can have different types of rosette appearance, right? So that's why I didn't put Ewing's, but yes, you are absolutely right in calling it as Ewing sarcoma also, right? So the answer is very simple, retinoblastoma. With respect to ophthalmology, there's been two more questions which might have relation to opthal as well as your pathology. If you have a tumor in the orbit which is positive for desmin, what is the diagnosis? I think this was an INACD recall. A tumor in the orbit which is positive for desmin, your diagnosis. Desmin is the immunohistochemical marker. I'm sure you know the answer. Great. Desmin is for rhabdomyosarcoma. Amazing. Okay. Rhabdomyosarcoma can be desmin, can be myogenin, multiple things like that, right? Perfect. Perfect. This came as a question before. Okay. Since someone commented melanoma, can anyone tell me the marker for melanoma? Though it's not related here. Since you commented melanoma, can anyone tell me at least one marker for melanoma? There are many markers, at least one. We have a marker called as an HMB45. Very simple to remember. I'll tell you how to remember soon. And melan A. Okay. If you have memorized HMB45 till now, it's the easiest mark, one of the easiest marker to remember. HMB stands for human melanin black 45. That's all. It's human melanin black 45 and melan A. It is in the melan, right? That also is easy for us to remember. S100 is superb. S100 is a very, very sensitive marker. S100 is not a specific marker, but I'll go for melan A and HMB45, which are very specific marker for melanoma. Fine. That's one. Okay. Fine. Next. I'll give you maybe a slight difficult question. Let's see if some of you guys can answer that. I'm having a patient who's having dryness of mouth and who is also having dry eye. And long term, the patient developed a very big swelling in the lacrimal region. On biopsy, what is the most likely tumor you will see in this patient? Yes, Pankaj. That's why I said it's non-specific. It's sensitive marker center. Patient with dry eye, patient with dry mouth. Can anyone tell me what's the syndrome I'm talking about? Syndrome is simple. Like Snehal just said, it's a classical case of an Sjogren syndrome. My question is now, what tumor is more common in case of Sjogren syndrome? Keratoconjunctivis zika, you're right. Sjogren syndrome, you're right. Tell me what tumor you can see in the lacrimal gland of Sjogren syndrome. Remember this, lymphoma. Fine. Sjogren, right? Autoimmune disorder. More and more damage and activation of the cells might result in lymphoma. Fine. Perfect. Just few questions with relation to eye and pathology. Fine. Great. Simple ones. Nothing much to remember. Maltomas, lymphomas, anything of that sort. We're going to have fast fire, rapid fire once you guys tell me the right answer here. Collagen. Collagen. Why collagen? Diagnosis? What's the diagnosis here? A patient presented with an arm span greater than the height with a subluxated lens and a pigeon chest appearance. Diagnosis most likely your Marfan's. Okay. And your option? Perfect. It is fibrilin gene. Okay. Great. Perfect. So now let's go with few rapid fire which has been asked with relation to Marfan, right? One is obviously inheritance. What do you think is the inheritance? guys to keep commenting the answer, right? I'll definitely fill the answer soon. There is a criteria named for Marfan syndrome. I want you guys to name the criteria for Marfan syndrome. What criteria? The name criteria which is there in Marfan syndrome. Fine. Next, I saw someone commenting that, so let's add that also. What is the chromosome where you see the fibrillin gene mutation? The chromosome where you have the mutation. Okay. Next, there's something called Marfan syndrome type 2. What is a mutation or what is a gene involved in Marfan syndrome type 2, which has symptoms similar to Marfan syndrome, just Marfan syndrome type 2, the gene involved. You guys are absolutely right on few things. Autosomal dominant, criteria as Gens or modified Gens criteria. Chromosome is absolutely right. Chromosome 15. Why am I not having answers for the last question? Because it is a little bit new, right? So please understand, if a question comes out of the box, it will eliminate things, right? Gene involved in Marfan syndrome type 2, we have a gain of function mutation in TGF beta receptor. Okay, a gain of function mutation TGF beta receptor might also cause Marfan syndrome. Do remember that. Fine. Great. TGF beta receptor should be gain of function mutation. Okay. The criteria is Gens criteria, Sindhu. It's nothing but the same thing what you read. The eyes, the length, the cardiac defects, and with the family history of Marfan's, I'm going to tell it's a Marfan syndrome. That's all. Fine. Okay. Superb. Just one question with Ehlers-Danlos. Inheritance. Few things with Ehlers-Danlos. Inheritance can be dominant, can also be recessive. I'm not saying only dominant. I do have few variants of Ehlers-Danlos syndrome, which is enzymatic defect. Fine. Okay. It's okay, crazy doctor. You must have known the criteria, but not the name. That's all. Now we'll learn the name as well. Fine. It's both autosomal dominant and autosomal recessive, right? Defect is primarily in collagen. I'm not talking about which collagen because different types will have different collagen involvement, right? Which of the type of Ehlers-Danlos has worse prognosis? Which type of Ehlers-Danlos has worse prognosis? And what will be the fatal incident which can happen in Ehlers-Danlos? The vascular subtype. Superb. The vascular subtype where I can have aortic dissection, which can make us lose the patient, right? Aortic dissection, the vascular subtype has the worst prognosis among the case of Ehlers-Danlos syndrome, right? Super, fine. Now next question again. It's a very simple question. Rule is simple. 10 seconds, don't read the question and comment on the right answer after 10 seconds. Please, let's follow the 10-second rule. Doesn't matter if your friend comments in the comment box first. It's not about who comments first. It's about who comments it right. Maro Asras Meghna, again. Please, not the first. I'm sure you know the answer. It's just the initial push made you comment the wrong answer. Please read the question. That's very, very important. Fine. Which of the following are true regarding PNH? Paroxysmal nocturnal hemoglobinuria, right? Great. It's acquired. It is not inherited. It's a genetic disease. I am not denying that at all, which means you, me, and anyone in the world can have PNH. It's an acquired disease. It's not inherited. The gene is PIGA gene, which is there in the X chromosome. It's not an inherited disease. It's an acquired disease. Fine? Perfect. Anemia with heart failure is the most common cause of mortality. Not at all. Can anyone tell me what's the most common cause of mortality in case of an PNH? That also was a very old PYQ. What's the most common cause of death in PNH? The most common cause of death or mortality in PNH is due to the thrombotic episodes. The thrombotic episodes, wherever it can go and block because of Budd-Chiari. I wouldn't say exactly Budd-Chiari. I'll keep it as thrombotic episodes. Stroke also can happen, right? Any thrombotic episode is the reason for death in case of PNH. Yes, Budd-Chiari can also happen, right? Next, sucrose lysis test is diagnostic. This, I'll put a question mark here because sucrose lysis test, acid hemolysis test were used long back. when I didn't have much of advanced test, right? So it is not diagnostic, but it can help me to narrow down PNH to some extent. It's a very, very old test. It's an obsolete test, so I'm not using it, right? Flow cytometry is the gold standard. Yes, this is the right answer. Flow cytometry undoubtedly is the gold standard for diagnosis of PNH. Few leading questions with respect to flow cytometry, fine? What marker, or like, let's say if I have to do flow cytometry for AML, I'll look for CD13, CD33, something or that, or MPO. What marker will use flow cytometry for PNH? Great. I like the answer what Sriraj gave. 55, 59, negative. That's important, right? It's CD55 and CD59 loss. If it's present, it is not PNH. It should be lost for me to say it's a PNH. Please don't forget that, right? Can anyone add one more stain? This is absolutely right. One more stain. Or you must have read that as there's one more test which is better than flow cytometer. What is that? Have you read a term called as flare? Have you read about flare? HAM is a very old test, crazy doctor. Have you heard about flare? FLAER? Flare is, it's a stain. It's also flow cytometry only. We think that it's some other different test. Flare stands for fluorescent, okay, aerolizin. It's a dye like your 55 and 59. Like Vivek said, fluorescent aerolizin, this binds to GPI anchor. Once it binds to GPI anchor, this is much more superior than my CD55, but it's not done because it's very expensive for me to keep a dye for a PNH which comes once in a while, right? This is the most commonly done, but if you have to ask which is the best is by default your flare flow cytometry, fine? Okay, that's regarding PNH. Again, one more question. Can I say PNH is an autoimmune hemolytic anemia? Sorry, PNH is an hemolytic anemia. Can I say that? Yes. Yes, perfect. Can I also say PNH is a patient will present with pancytopenia? Yes, I can say that as well. If a patient presents with pancytopenia in a OPD and you're going to do a bone marrow aspiration, what will you see in bone marrow aspiration? It's a very important question. What is the bone marrow finding for PNH? Though we don't do it, if I am going to ask a theoretical question, what will you see in bone marrow for PNH? What is in bone marrow for PNH? Bone marrow will have cellular hyper or just cellular marrow is more than enough for me, right? There's a very rare combination, pancytopenia with a cellular bone marrow. The reason why there is a cellular bone marrow is, I asked you a first question. It's a hemolytic anemia. When I have hemolysis, obviously the cellularity increases. I can call it hypercellular or a cellular bone marrow, right? That's important. There's a combination which we generally don't get. If it's pancytopenia, we generally tend to have an hypocellular bone marrow, but here it'll be a cellular bone marrow, fine? Marrow, if the question is only combination, I would say it should be not hypocellular. I can have normocellular or I can have an hypercellular. That's how it is. It will not be paucicellular or it won't be hypocellular. Fine. Okay. That's the answer. Fine. Okay, Mara. Fine. Let's go to the next question. Simple question. First, let's look at the image. Then let's look at the question. Tell me what is the cell you're seeing here? What is cell? It's a classical acanthocytes, right? Perfect. So now let's look at the option. What could be the most probable answer here? Those are classical acanthocytes. You're absolutely right. An adult male presents with protruding abdomen, diarrhea, visual symptoms, and neurological manifestations. Based on the peripheral smear, I'm seeing this. My diagnosis, undoubtedly, A beta lipoproteinemia. Fine. Great. Now, uh, A beta lipoproteinemia, as the name says, there is no beta lipoprotein in my body because of an absorption defect. That's why intestine has a problem, right? So if beta lipoprotein is not there in the body, my cell membrane, which is a phospholipid bilayer, will not be perfect. It will have very wavy appearance, right? That's a problem here. So both A beta lipoproteinemia and also liver failure. See, liver failure, can I say I'll have difficulty in beta lipoprotein? It will have difficulty in beta lipoprotein production. Both will cause acanthocytes. Fine. Okay. What will be the microscopic change in case of burns, in case of uremia? Any cell? I'll have irregular blunt spikes in case of an acanthocyte. What will be there in burns and what will be there in case of an uremia? You'll have burst cell. A burst cell or an echinocytes, right? Perfect. Here it's a spur cell or an acanthocytes. Actually, burst cell can also be an artifact. That's why EDTA changes there. But if I see uniform burst cells, I'll think of a CKD or a burns patient, right? Okay, next. Where do you see codocytes? Where do you see codocytes? I'll name a few more cells. I want you to tell where you see them. Where do you see a drepanocyte? Marrow, I can have that also because burns will cause hemolysis, physical. I can have a spherocyte as well. Where do you see a dacrocyte? Burns can also have spherocyte because burns can also cause hemolysis. Fine. Okay, codocytes are nothing but target cells. TAL, IDA would be my first cause. Very severe case of an IDA. Drepanocyte is the other name for sickle cell. Drepano means boat. It looks like a boat. Sickle cell anemia. Okay. Dacro is your teardrops. You see that one? Myelofibrosis. Okay. We know what is a sickle cell, but if the question is like drepanocyte, you should not miss it. Fine. These are the other terms which you might probably come in an exam. Fine. Okay. I'm sure whenever we wrote target cells, the mental image of a target cell must have popped up, and sickle and for dacrocytes as well, right? Great. Next question. Very simple one. Yes, Adi. If you make mistake in this, it's tough, right? It's APTT, right? Activated partial thromboplastin time. Few questions regarding coagulation pathway. And one more thing, what I'll be doing is I'll be giving different permutation combinations. I want you to tell what's the most probable diagnosis. Ready for it? Okay. First, what is the anticoagulant used? And also I want the color of the anticoagulant, the cap, the tube's cap. What anticoagulant will I use for PTA, PTT? And what will be the cap color? Anticoagulant is, I thought you will definitely tell that. Yeah, light blue color. If I have to say, I have to use perfectly, I'll use the term light blue. What's the anticoagulant name? Sodium citrate. Perfect. Okay. Sodium citrate or a citrated blood or a trisodium citrate, or like SS said, 3.2 is the ratio of trisodium citrate, whatever it is, and light blue color vacuum is what I'll be using, right? Next, let's look at different permutation combinations. Let's see if you're able to answer that, right? Okay. PT is elevated. APTT is normal. Platelet and your clotting time, bleeding time is normal. What is it? Nitu, that's purely based on memory. You have to memorize it. Elevated PT, normal APTT. What's your finding? What do you think of? Extrinsic pathway is absolutely right, but factor 7 deficiency is very, very, very rare. Trith Modi, warfarin. Warfarin, what all it blocks? My first possibility here is an early stage of liver failure. I want you to remember that first. How many of you here are intern or post-intern? Can you comment yes if you're an intern or a post-intern? If you're an intern or a post-intern, you can easily relate this and you will never forget it. Liver function test, when you do, PT is a component of liver function test. Right? Have you done that? whenever you've done a PT, whenever you do a liver function test, PT will be a component, because that is the first change which will happen even before SGOT and SGPT, right? Because prothrombin time, factor 7 will be destroyed, very short half-life, and that happens, right? You must have definitely remember that, don't forget that. Obviously, after saying this, factor 7 for the theoretical answer will come. Von Willebrand, I will not think of this. Von Willebrand, I'll think if it's an isolated APTT prolongation, but von Willebrand is bleeding disorder, right? Coagulation might not interfere with von Willebrand at all, right? Okay. PT normal, APTT prolonged, what will be your first thought? What will be first thought? Normal PT, elevated APTT. My first thought is always here. Here I will rule out von Willebrand disease, because von Willebrand this time also in the INICT came. This is the most common inherited bleeding disorder. Rule out von Willebrand. Don't jump into hemophilia. Always rule out von Willebrand first, because that's most common. Rule that out first. Then yes, you're right in thinking of hemophilia. If I have an isolated APTT prolongation, okay, this also came on an exam. What's the next step? Is the next step doing a factor assay or is something else? Isolated APTT prolongation, the next step, will you do factor 8 assay or is there any other test? You should not do a factor 8 assay. If there's an isolated APTT prolongation, the next step is something called an mixing studies. You have to do a mixing study. Mixing study will help me to identify whether it's really a factor deficiency or I have an antibody formation against factor 8. Then I'll go and do a factor 8. The next step is mixing study, right? Great. So I have PT also elevated. We have APTT also elevated. What will be a possibility? PT elevated, APTT elevated. What's a possibility? Liver failure or a common pathway defect, right? Can I say warfarin will come into this as well? Hi, Niket. I'll come to DAC soon because it's too early for me to suspect DAC when just PT and APT is elevated, right? Will warfarin also cause this? Vitamin K dependent factors 2, 7, 9, 10? It can, right? Warfarin. Okay, Snehajit, thrombocytopenia will not even alter the coagulation profile. Remember that, fine? That also can happen here. Again, you'll have a history of warfarin for that, right? PT elevated, APTT elevated, TT stands for thrombin time. Thrombin time elevated, fibrinogen levels are reduced. What's the diagnosis? I didn't think of DIC in PT and APTT because it's a bit different. Here I would think of DIC, right? Here I would think of DIC, or like Nitu said, afibrinogenemia could also be a possibility for me, but again only fibrinogen levels will help me to identify what it is, right? Okay, DIC, fine. Now there's a question with respect to DIC, just one-liners which has been asked previously. Tell me a sensitive test for DIC. Tell me a specific test for DIC. And tell me which test will determine the bleeding tendency in DIC. I'll tell you in detail if you're not understanding what do you mean by bleeding tendency. The sensitive test is D-dimer or specific test is D-dimer? D-dimer is a very specific test, right? D-dimer is a specific test. Sensitive test, I prefer an FDP, fibrin degradation products, though it is not done. I prefer an FDP for a sensitive test. Third question, this was an INICT recall and bit of an old INICT recall, but it's very, very important. A patient is bleeding in DIC. I need to do one test just to document the patient is having bleeding and confirming that's due to DIC. Which is not so useful in OBS, Marrow? D-dimer? Definitely will be useful. Not D-dimer. Bleeding tendency is always based on fibrinogen level. Okay. Bleeding tendency in DIC is based on the fibrinogen levels, right? TEG, if I have, great. TEG is only theoretical. It's very difficult for us to have TEG and it's very, very expensive also. The fibrinogen level determines the bleeding tendency in DIC. Why this is important is DIC is both problem of bleeding as well as problem of your clotting, right? It's a both of them will happen. So treatment should be based on what state the patient is. If the patient is having thrombotic states, I might use anticoagulants. If the patient is having bleeding tendency, I might give FFP. So if I have to know where the patient is to identify if it's a bleeding tendency or a thrombotic tendency, I use fibrinogen levels, right? It's a very practical thing which is important. This was asked once in INACD exam. DIC's bleeding tendency will be determined by the fibrinogen levels, fine? Okay, let's go to the next question. It's a simple one. If you've done PYQs, you will definitely write the right answer. I hope my voice is fine. I think it was second, there was a problem. Maybe crazy doctor. I don't know. Okay, great. Tell me what's the answer. Think an answer. Need not be in a hurry. Okay, C, B, C. First, let's draw a chart for this. To draw a chart, we need to know the genetics or the genotype of the parents, right? Now, can I consider, tell me yes or no. Can I consider the mother's family, leave the mother's family, the mother. Can I consider the mother here to be a carrier? Yes or no? Can I say here, mother is a carrier with confidence? Yes or no? I can say here, mother is a carrier. The only reason I am very confident in saying mother is a carrier is they already have a child with hemophilia. If the child is having hemophilia, someone should give the gene, right? So the mother is a carrier, right? Let's assume X chromosome, right? Mother is a carrier. And father is written normal. Father for an X-linked recessive disease cannot be a carrier. So the father is absolutely normal here, right? Okay. Capital X, small y. Capital X is for normal and small x is for affected, right? Okay. Now let's do the permutation combination. Capital X plus capital X and Y, small x and capital X, small x and Y, right? Can I say this permutation combination is fine? The Punnett square kind of thing, a pedigree. This has to be done. If you have a question like this, please don't guess. You have 45 seconds to 1 minute. Consume that here. Write it so you will not have an error. Now, 50% of the males are affected and 50% of the daughters are carrier. Okay. Please, for anything with respect to genetics, if it's a relative risk calculation, don't memorize. You might end up in error. It's very simple. It will not take more time, right? I hope NB at some point of time will give pencils. If not, scribble in the desk. Please do this. Half of the males will be affected and half of the females will be a carrier. Option B is the right answer. All males will not be affected in an X-linked recessive disorder. Is that clear? How to derive mother as a carrier is they already have a male child with hemophilia, which means genetically they have a faulty gene and it's also given father is completely normal. Father cannot be a carrier in an X-linked recessive inheritance, right? Great. Answer. This is a PYQ, so it's easy to answer. Diagnosis. RB gene mutation. Okay, 10-year-old boy, fever, right upper limb pain, has an expansile lesion involving diaper disease. So I'm considering a bone lesion, right? Uh, Satya, like hemophilia is an X-linked recessive, right? Cannot be dominant. So I think of an Ewing sarcoma, right? Perfect. That's my diagnosis first, right? Now, can anyone tell me what is the structure in Ewing sarcoma? I'm circling something. Can anyone tell me what this is? What comes to your mind when you look at this? It's a very simple one. you think of, that's your rosette, right? I can call this an Homer-Wright rosette. Okay, so it's a small round blue cell tumor along with the Homer-Wright rosette, diaphyseal lesion. My most probable diagnosis is Ewing sarcoma. Now the question is, what is the gene which will be involved in Ewing sarcoma? EWSR1 stands for Ewing sarcoma related gene, and the fusion with your FUS fusion, that's the diagnostic test for Ewing sarcoma. RB gene will be the answer if the clinical history is an osteosarcoma. Fine. Okay. Okay. So there are few things which come in Ewing sarcoma with respect to Ewing sarcoma. There are markers. We have very old markers. At the same time, we have very, very advanced marker. Tell me one marker, immunohistochemistry, which comes to your mind when you think about Ewing sarcoma. Anything. Any one marker. Any one marker. CD99. Perfect. Okay, CD99 by default is the oldest marker. Anything beyond that, after that, CD99 is a very, very non-specific marker. Some lymphomas also will be positive for CD99 or MYC2. MYC2 and CD99 is one and the same. We have a marker called as FLY1. That also is a very good marker for Ewing sarcoma. After FLY1 also has been asked in exam. There's a new marker after FLY1. That's the recent marker which is being used. If at all a new question comes in INICT, if you're preparing for that, please do remember NKX. It's NKX 2.2. This is the most specific marker with respect to Ewing sarcoma. Please do remember them. Fine. Both your translocation 1122 EWS fusion gene will be seen in case of Ewing sarcoma. This is the way by which immunohistochemistry has evolved with respect to Ewing sarcoma. And there's one more stain which Ewing sarcoma genes will be positive for. The cells will be positive for. Not the genes, the cells will be positive for. The reason is it will pick up glycogen which is there in Ewing sarcoma. Can anyone tell me the stain? I was supposed to ask that next. Can anyone tell the stain? Pass. They are PAS positive because Ewing sarcoma cells, they do have glycogen in them, right? If I have to demonstrate the translocation with respect to Ewing sarcoma patient, what will I prefer? Karyotyping or fish? What will you prefer? If you have to demonstrate the translocation, I generally prefer fish. Any translocation which I know what chromosome I'm going to look for, specific is always fish. Be it a CML, be it a leukemia, be it a sarcoma, be it a lymphoma, always I go for fish only. Fine. Okay. Next question. Read the question, look at the image and tell me the answer. Okay, Vivek has started. It's saying C. Let's see how many of you can join that. C. Okay, primary diagnosis. These type of questions are very interesting, no? The NEET PG recently has been given you a good set of questions. Enjoy the exam. I know it's an irritating exam, but still, these are good questions, right? Diagnosis is plasma cell leukemia or a plasma cell myeloma or a multiple myeloma. Fine. Okay, I cannot call it a leukemia. I'm going to call it a myeloma. Fine. Bone marrow showing 22% plasma cell. That's one of the important diagnostic feature for me to push as multiple myeloma or a plasma cell myeloma. Fine. Great. So the thing here is this. The eosinophilic deposit, what you're seeing here, that's diagnostic and that's your amyloid. Extracellular, acellular, amorphous deposit anywhere in the body, I think of amyloid always, right? So bone marrow is not having necrosis. Myeloma will not cause necrosis of the bone marrow, neither fibrinous not coagulative. This is not a degeneration of a bone marrow. It's a classical case of amyloidosis secondary to your plasma cell myeloma or a multiple myeloma. Fine. So tell me, if I have to take this protein, what type of amyloid protein will it be? Will it be an AA amyloid? Will it be an AL amyloid, right? You guys can guess my question by this time, right? That's what I want you to do when there's an exam. Guess the question. You'll know where it is directed if you know the topic, right? It has to be an AL amyloidosis, right? Amazing. Fine. So AL amyloidosis is what I'm going to see in patient with a myeloma. This is the most common type of amyloidosis. Kidney can also have the deposit. Bone marrow can also have the deposit, right? Since we are an amyloid, let's discuss something related to amyloid. I'm going to write the amyloid protein. I want you to tell what's the most common disease which comes to your mind first. I'm not going to write A next to you. Because you know that I'll write A next, right? Let me write A beta. The next one is I'm going to write A beta 2M. Where will you see A beta amyloid? And where do you see A beta 2 microglobulin amyloid? And where do you see ACAL? A beta is for Alzheimer's disease, right? Beta 2 microglobulin is for chronic hemodialysis related amyloid. ACAL is for, you guys didn't comment for ACAL, so I want you to comment for ACAL. Then IAPP. Perfect. ACAL is a localized amyloidosis seen in case of an medullary carcinoma of thyroid. Where do you see IAPP? IAPP? Islet amyloid polypeptide. Where do you see them? Islet amyloid polypeptide. Great. I'll write two things here. I can see them in insulinoma, a tumor, and also I can see them in diabetes. The question is, type 1 or type 2? That's a question, right? Tanya has posed a question mark there. Type 1 or type 2? Where do you see? It is seen in, great, it is seen in type 2 diabetes mellitus. Only in type 2 diabetes mellitus, there will be more protein production, more deposition that results in amyloidosis. It's not in type 1. Type 1 is insulin dependent, no insulin. When there's no insulin, there cannot be an amorphous protein which is deposited. It's always in type 2 diabetes mellitus, right? Please remember that, fine. Okay, since we are still in amyloid, let's ask a little bit more questions in amyloid. Amyloid, what type of protein is it? Is it an secondary folded protein or a primary folded protein or a tertiary folded protein? If it's secondary, what type of secondary? Amyloid is a, just take one more page. It's a beta pleated sheet, right? It's a beta pleated sheets. To be very, very specific, it's a non-branching fibril of a beta pleated sheet. Okay, great, amazing. So which is the best place where you can take biopsy if I'm suspecting a patient with amyloidosis? I'm not talking about renal amyloidosis. I have to take a kidney biopsy. If it's generally suspected amyloidosis, what place where you'll take biopsy? The most sensitive area to take biopsy is in abdomen fat pad for a generalized amyloidosis. Like I said, in a localized amyloidosis, I can take it from the organ where it is involved. Generalized, it's an abdomen fat pad because of the vascularity, right? Perfect. So let's say I've taken an amyloid biopsy in light microscopy. In a HNE, it's going to be pink in color. So what's the stain we use for amyloid? There are multiple stains. Amyloid can also be positive for PAS. Amyloid can be positive for thioflavin. There are multiple stains there, right? But let's say I'm using that stain, what you will say, which is Congo red. What's the color of Congo red amyloid? Leukocyte also it will be positive, right? We don't use those things. The common thing which is used is in the lab is Congo red. I don't even have thioflavin in the lab. It's there. I don't even have leukocyte in the lab, right? Congo red is commonly used one, right? So what will be there in the light microscopic structure after using Congo red, and what will be there in case of an polarized light after using Congo red? Perfect. Salmon pink. Salmon pink is an orangish color of pink which is seen in light microscopy, and in polarized light you will see your apple green birefringence. Please, whenever there's a question on amyloid, don't jump and write apple green. The reason is it will be seen only in polarized light. It will not be seen in light microscope, right? There's one question which came in INICT because INICT initially had some association reasoning type in between. Then they removed it. Thank goodness they removed it, right? So there is a question which is asked. When you have Congo red, why does Congo red stain amyloid? Why does Congo red produce the apple green birefringence? Because Congo red can bind the fibrils. These are the non-branching fibrils. These are the fibrils of amyloid, and Congo red is a person which can go and bind to the fibrils. Imagine there are two pencils here, two fingers here. They will not produce shadow if they are non-branching, right? If I have an Congo red in between, that will reflect the light. That's what causes polarizing effect, right? They bind the fibril and that gives the polarizing effect in case of amyloid. Came once in INSAT. If you can remember, do remember that, right? Okay. Tell me, what will be the best test if you have to just ask theoretically? Best test to identify the structure of amyloid protein. What will be the best test for structure of amyloid protein? Again, it's a theoretical question. Practically, no one does that. In other words, in biochemistry, which test will help me to identify the protein structure? That's all. Biopsy will not help me to identify protein structure, right? Perfect. X-ray crystallography. I can pick up the protein structure in X-ray crystallography. If that is not there in the option, look for electron microscopy. If X-ray crystallography is there, X-ray crystallography by default is the best answer, right? Mass spectrometry will not help me the structure, but X-ray crystallography can easily give me the structure, right? Great. Okay, this was again a question which was considered difficult, but it's actually a very, very simple question. If this came as a new question, I'll tell you how to decipher it. Tell me the answer first. You know the answer now because it's a repeat question, right? If this was an initial question which came as a new topic in exam, how do I handle this? First of all, there's not an electrophoresis. We have something called an immunofixation, right? It's actually an immunofixation. I'll tell you what does an immunofixation means. Okay, before that, I need a little bit of help from you to tell me the serum protein electrophoresis finding in case of multiple myeloma. What's the serum protein electrophoresis finding in case of multiple myeloma? What do you see in serum protein electrophoresis? There's one spike, your M spike or the myeloma spike, right? Or the monoclonal myeloma spike, fine? That's a classical finding there. Now, have you seen this image? You'll have albumin, alpha 1, alpha 2, alpha beta, and gamma globulin. Not so great. A gamma globulin spike, and this must be written as an M spike. You must have definitely seen this image, right? So now tell me, this M spike, is it very classical, or can I say a patient has infection, chronic infection? Will the globulin increase as well? Possibility is there. When it becomes classical is if entire M spike is made of a single immunoglobulin, because in infection it will be polyclonal. In tumor it will be monoclonal. So what we do next is this, I push them into a process called as an immunofixation. So that's what has been seen in this image. I take that M spike and do an electrophoresis again. So when I do an electrophoresis again, look at this. You can see that I have a beautiful band in M. That's IgM. This is your IgG AM kappa lambda. I have a beautiful band in M. I have a beautiful band in kappa. There is no lambda. Again telling it's monoclonal. It's not polyclonal, right? So this is called an immunofixation. After doing an M spike, I take that, do an electrophoresis again, which gives immunofixation. So it's a classical. If I can be perfect, it's IgM kappa multiple myeloma, right? Okay. What are the criteria you know for myeloma? I'll explain the criteria also with this image. This image, a beautiful image, as an absolutely wonderful question which came in the exam. Narrow K and L stands for the kappa and lambda light chains. Electrophoretic pattern. Yes. G band is not beautiful because when the bone marrow is so much proliferating, G is not in a single molecular weight. That is just a gradation of G. Crab and slim, right? Perfect. Let's not go into crab. Let's leave crab. Crab is very, very ancient, right? Let's look at slim. So what all stands in slim? S, L, I, M, right? S for Satya, and someone else has also asked, I have to have a band. A solid band tells me it's more concentrated, not a diffuse thing, right? 60%, right? 60% in the bone marrow, I'll obviously think of a myeloma. M for the MRI, focal lesions in the MRI, fine? If you remember LI is your light chain ratio. Do you remember that? Okay. There must be value for the light chain ratio also. Now look at this image. It will explain the slim. If you look at this image, K is kappa. I'll write this for your convenience. kappa light chain, L is your lambda light chain. Now tell me, can I say the light chain ratio is tilted to kappa? There's no lambda at all. If you remember, more than 100 times, when I have involved light chain to uninvolved light chain, I call it myeloma. That's the slim criteria. So here again, it is monoclonal. Only kappa, lambda is not seen, right? When I have involved to uninvolved, I cannot have numbers in electrophoresis. I can have only bands. It's not a quantitative test, right? So if you have light chain ratio of more than 100, involved to uninvolved, that's what is seen here. Kappa is very thick, lambda is not even seen. That's your slim criteria, right? This can explain your slim criteria and obviously M-spec and your monoclonal protein, right? So what's the most common type of multiple myeloma? Anyone? Which subtype do you think is most common? G or M or A or D? Most common is IgG myeloma is most common. There's an M myeloma, right? The most common multiple myelomas of IgG type. M can also happen. Nitu, can you ask me at the end of the lecture? Let's complete this. If you want to easily categorize them, okay, let's complete it because I'll forget it after that. We have MGUS, we have smoldering myeloma, and we have multiple myeloma or plasma cell myeloma. Fine. Nishita, IgG subtype will have the strong band in IgG and nothing else will be there as a strong band and kappa or lambda, whatever it is. Fine. So generally we take M spike as one criteria, percentage of plasma cells as one criteria, and let's assume CRAB or clinical features as one criteria. Okay. This is how we differentiate them. One, give me a second, I'll complete this and I'll tell you how it looks like. Fine. Okay. Multiple myeloma, M spike, see I'm writing plus, but there are few, like 3% of them will be non-secretory myeloma where I might not have that, fine. And plasma cell percentage of more than 10. I'll write in bracket 60 for the slim. CRAB criteria should be present. Okay. Smoldering myeloma, again, M spike will be positive or maybe negative also. Plasma cell, what will be the plasma cell percentage of smoldering? The newer criteria says it's 10 to 60%. Fine. But it differs. If I'm using older one, it differs from the newer one. Smoldering myeloma will be negative for the CRAB or the slim criteria. Fine. Okay. Can anyone comment what does MGU stands for? What does MGU stand for? MGUs is the most common plasma cell dyscrasia, which is monoclonal gammopathy of undetermined or uncertain significance, right? So MGUS will not have any finding. So in MGUS, I'll have the M protein negative or the amount of M protein will be less than 3 grams per deciliter, fine. Plasma cell percentage will be less than 10% and CRAB or slim will be negative. Easiest way to identify is if CRAB or slim is positive, it's myeloma. CRAB slim negative, I have only two options. Look at this. Less than 10, put as MGUS. More than 10, put as smoldering. That's the easiest way for us to differentiate them. Fine. Okay. Okay. Now let's look at this. Some of you asked, how will polyclonal look like? Polyclonal will have here also. May not be in the same level. We'll have here also. We'll have here also. That's how polyclonal looks like. Fine. Okay. That's in short about how the criteria go with. Please stick to CRAB and slim. CRAB positive myeloma, CRAB negative more than 10 smoldering, CRAB negative less than 10 MGUS. That's the easiest way to remember that. Fine. Okay. Next one. I know you know the answer. It's a very simple one, but let's still see how many of you tell it right. What's the answer? Phyllodes. Option D, right? It's a very, very simple one. Like I said, most of you know the answer. Okay, great. It does not look like a leaf, right? But we always read leaf-like appearance, right? So first and the foremost clue for Phyllodes tumor. The first and the foremost clue, always the size of the lesion and the recurrence. These are the most important clue. You must have seen Phyllodes. Patient come back with Phyllodes again. That's an important clue in here. She had a history of similar lump for which excision was done, but not available. Came back. Recurrence is always Phyllots. 10 centimeter lesion, first is Phyllots. I won't even think of IDC. First, you'll think of Phyllots, right? Second, obviously in microscopy, you have the leaf-like appearance. It doesn't look like a leaf-like, it's a stromal overgrowth. The stroma is more, I think of a Phyllots. That's all, it's for Phyllots. Is Phyllots benign or malignant? What do you think? Phyllots is benign or malignant? Phyllots is benign, borderline, as well as malignant. Okay. Phyllots is an epithelial tumor or a stromal tumor? Sneeze your fresh in memory the third gene. Phyllots has all three gradations, benign, borderline, as well as malignant. Phyllots is a stromal lesion or a mesenchymal lesion. This is not an epithelial lesion, it's a mesenchymal lesion. If it becomes malignant, it can become a fibrosarcoma, something of that sort, fine? Okay. Let's say, I'll give you a few more clues with respect to breast pathology which has been asked. A mobile mass, you know the answer, right? Breast lesion, mobile mass, what's the first thing which comes to your mind? Comment on it. FNAC shows cohesive clusters. Diagnosis? Breast biopsy, breast lesion, mobile mass, undoubtedly fibroadenoma, and this also came once in exam. Cohesive clusters in FNAC, think of fibroadenoma. If it's a cancer, it will be discohesive. Cohesiveness is always for fibroadenoma or a benign condition here, right? Okay. Now, let's say a bilateral lesion, and if I give the next clue, you will tell me the answer. Popcorn calcification will lead to the radiologist for now. Microscopy shows, should I tell? Okay, let's tell. Let's make you happy. Indian file pattern. Diagnosis. Diagnosis. Amazing. Lobular carcinoma of breast. Okay. This also came once in exam. Lobular carcinoma. Are they ER positive or ER negative? ER/PR positive or negative? Lobular carcinoma is estrogen receptor positive tumor. Do remember them, right? Long term is poor prognosis. Short term, because of ER positivity, they have a good prognosis. ECADN is negative. That's very, very unique for lobular carcinoma. Someone talked about LCIS. LCIS, is it benign condition or a pre-malignant condition? I'm sure the surgeons must have updated this. LCIS, from the past 3-4 years, we are considering it as a benign lesion. We are not considering it as a malignant lesion at all. Fine. Remember, lobular carcinoma in situ is not anymore pre-malignant. It is considered as a benign condition. Fine. Okay, it's a benign condition. It's not a pre-malignant condition at all. Right. Okay. Few more questions here. Let's say a patient with a nipple discharge. The patient has scaling in the nipples. Underlying there's an irregular mass. Irregular mass in the breast, scaling and nipple discharge. Diagnosis? I'll give you a clue. It's a spread of a tumor. Paget's disease. Paget's disease of breast definitely is a possibility. It can go from the DCIS or an IDC and can go into your nipple areolar complex, right? One of the closest DD is eczema here, right? Okay. So what's the most common subtype in case of an molecular classification of breast? There are 4 different types of molecular classification: luminal A, B, HER2 enriched, and case of an triple negative. Which is the most common one? Most common subtype is luminal A, and luminal A also has the best prognosis. Fine. It also has the luminal A is the most common. Luminal A also has the best prognosis. Fine. Okay. Triple negative is not that common. Triple negative has the worst prognosis, if I have to say that. Fine. Okay. Which is the most important prognostic marker or prognostic finding in case of breast cancer? This came in the last about one NEET exam. Most common prognostic finding or most common prognostic marker with respect to breast cancer. The most common prognostic sign or prognostic feature. Can you be a little bit more? KI no, hormonal no, HER2 no. Naman, can you be a little bit more specific? The most common prognostic thing or most important prognostic feature is perfect lymph node involvement. The axillary lymph node involvement is the most important prognostic finding with respect to breast cancer. Don't forget that, right? ERPR status comes later. Either I can put as TNM staging or, to be very specific, the lymph node involvement. Fine. Okay, great. Next question. A simple one. Answer. Patient passed away due to following an MI and autopsy was conducted. Biopsy shows his finding. Oh God, it's okay. A, 7 to 10 days. Why 7 to 10 days? Let's look at some. See, there's a PYQ. I told I would just take a NEET PG PYQ. If you remember the NEET PG PYQ, you know the answer, right? This image. Can you see the 5 lines here? Can I say these are the skeletal muscle striations? Yes. Perfect. This is a live tissue or a dead tissue? There are nothing but skeletal muscle striations. This is a live tissue or a dead tissue? It's a dead tissue, right? I'm not even going for reperfusion injury. These are not your eosinophilic thick bands. They are not the eosinophilic bands. They are not the wavy fibers also. These are nothing but normal striations. Normal striations of a cardiac myocardium, but it's been dead. It's been dead. The reason I still am able to see the fiber is it's a coagulative necrosis. That's all I'm seeing here. It's a patient with an coagulatively necrosed myocardium. Can are you seeing inflammatory cells here? Yes or no? Are you seeing inflammatory cells in this biopsy? Myofiber disarray, Sriraj, it is not even in my MI, it's in a tumor. It's in a cardiomyopathy. Let's not comment on that now. There is no inflammation here, right? Perfect. There's no inflammation. Amazing. Fine. If it's only dead fibers, that's coagulative necrosis without inflammation, I would think less than a day. Okay, around 4 to 24 hours is what the average age is, right? So 0 to half an hour, what's the finding? Waviness of fiber, the entire fiber will become wavy, not a part of the fiber, right? Please remember, this is not, the image is not a waviness of fiber. That's a very, very early onset finding. Sorry, half an hour to 4 hours. 0 to half an hour, I'll see nothing. Half an hour to 4 hours, I'll see waviness of fibers. Fine. Those are blood vessels, Pankaj. Sorry, Nitu. Inflammation, Pankaj, you will have neutrophils. You can see neutrophils, the bent nuclei. That's what inflammations are. Fine. Okay. 4 hours to 24 hours, that's approximately a day. I will see only necrosis, like in our patient. Only necrosis, no inflammation. 1 to 3 days, I'll have both necrosis plus inflammation. How can I see an inflammation? You will see them as blue cells, tiny blue cells, tiny WBCs, that's all. Fine. Mottling is gross, very difficult to pick up in gross. Microscopy, if you remember, that's more than enough, right? 4 to 7 days. What do you see? After neutrophils goes, which guy will come? Macrophages come inside. Fine. After macrophages, 7 to 10 days, or even sometimes 7 to 14 days, I'll be seeing granulation tissue. And anything more than 2 weeks, I'll see scar, the collagen scar. Fine. There's a timeline of infarct post MI. Fine. One important thing I want you to remember, which you can relate it to surgery as well. Okay, Sriraj, granulation tissue, if this image is having granulation tissue, it'll have multiple tiny blood vessels. Okay, it'll have multiple tiny blood vessels. Then I can say it's a granulation tissue. You will see RBCs also. Fine. Okay, then I can call the granulation tissue. Here I'm not seeing the granulation tissue. Fine. Okay. Okay. Now, can I say, how do you differentiate macrophage and neutrophil? Macrophage is foamy macrophage. Macrophage will be clear appearance. Macrophage eats every fat and dead particles, right? That's how you identify. Neutrophils, you'll have nuclei. The neutrophil nuclei will look like this. It'll be like a bent nuclei. You must have seen neutrophils. If not, go back and see any neutrophil in your books. It'll be a bent nuclei. If you have cells with multiple clear cytoplasm, it's a macrophage. These one, see, again, Satya, I have such a big image in that there are 1, 2 cells. That's fine. Look at the predominant finding. Fine. Okay. So can I say when there is only macrophage, that's the weakest moment in the entire healing process. Initially, I had at least dead cells plus neutrophils. Then I had granulation tissue. Granulation tissue also will have collagen, right? Macrophage only is the weakest time in an MI, which means there is more chance of rupture. The timeline of rupture of myocardium is always due, either the free wall or the septum is always due to 7 to 4 days. Now, think about surgery. Have you heard about something called in burst abdomen? That's an important topic in surgery, right? Burst abdomen. Have you heard that? This way is SFT, neutrophils, and clear macrophages. Burst abdomen, if you remember, every book says around 5 to 8 days. It's not about burst abdomen, it's about a secondary wound healing. Any wound healing which heals by secondary intention always is weak around 4 to 7 days or 5 to 8 days. That's wound healing, not burst abdomen. Same as here, wound healing. That's the weakest point. That's where it can rupture. That's all. Fine. Okay. Now, okay. What type of collagen will you see in granulation tissue? What's the type of collagen seen in granulation tissue? It is type. And what's the type of collagen seen in scar tissue? Type. Granulation tissue has type 3 collagen. Scar tissue has type 1 collagen. The strongest collagen, type 1 collagen, right? Pankaj-Dressler syndrome is post-MI myocarditis. It has nothing to do with this. Great. Perfect. Okay. Simple one. I will not take much time in this to discuss. You know the answer. It's a straightforward one. Which of the following is... I'm not reading the question. I hope you guys read this. Incorrect. Okay. Meghna, if you're not read incorrect, Soumyashri, if you're not read incorrect, comment here. You did a silly mistake so that you will not forget it in the real exam. Because this is very tempting, right? Free serum iron is toxic to cells. Everyone knows that. But if you have missed incorrect, you will write that as the right answer and go ahead, right? It's fine to make mistakes. Correct it here. That's why I'm asking everyone here to comment. Fine? Please do comment. Okay? This is right answer. Iron is stored in the form of ferritin. Right answer. Serum ferritin denotes the iron levels in the body. It's a storage component. Right answer. Iron is transported binding with apoferritin. How is iron transported? Iron has two things. If I'm talking about transport from the duodenum to outside, it's ferroportin via that, right? If I'm talking about from there to your bone marrow, transferrin. It's not bound with apoferritin. Apoferritin is a ferritin's precursor. It's a storage form only. Fine. Okay. Apoferritin is nothing but ferritin's precursor. It's a simple storage form. Fine. Okay. Let's quickly recap the iron metabolism. Again, based on simple questions. Which part of the body iron is metabolized? Iron is metabolized in the duodenum. First, second part, whatever if you can, great. But for me, duodenum is more than enough. Which ion will be easily absorbed? Fe2 plus or Fe3 plus? Which will be easily absorbed? Like someone answered here, DMT1. DMT stands for divalent metal ion. So has to be Fe2 plus. With the help of divalent metal ion transporter, DMT1, Fe2 plus goes. Fe3 plus also will go, but 2 plus is more important for me. Once it goes inside, it will be stored as ferritin. From ferritin, for me to exit outside, I need the guy, porting guy, ferroportin, right? So once it goes to ferroportin, what happens here is the iron which comes outside is toxic. Iron can never be free. So how do they divide? Iron can never be free in my body. So iron binds to two places. Iron binds to transferrin, that is one, and also ferritin. Whatever we do in blood test is this serum ferritin, not this ferritin. No one can identify the duodenal ferritin. I can identify only the serum ferritin. Serum ferritin is 10% of the iron. Transferrin is 90% of the available iron. 10% goes to store, rest goes to transferrin. Transferrin takes us to the bone marrow, the enzymes, wherever iron is being useful. Transferrin has one more role. Transferrin also goes and binds to the liver. Liver has receptors for transferrin, where transferrin comes and binds here. Once transferrin binds, my body knows I have good quantities of iron. So who will they release? Who will they release? The body releases. The liver produces one more guy. That's also dubbed as master regulator of iron metabolism, hepcidin. What does hepcidin do? Will they reduce the exit of iron or will they increase the exit of iron? Hepcidin will go and block this guy. Will go and block your ferroportin so the iron reduces. Fine. It reduces or inhibits your ferroportin so that the iron exit will reduce. Right? This is a simple iron metabolism. Hepcidin is a master regulator, enters and the cycle continues. When my body is not having iron, transferrin cannot come and bind to the liver. Hepcidin will not be produced. No one to block ferroportin. More and more iron goes outside. Fine. Fine. Satya, I will take this 3 plus and 2 plus sometime later. There are lots of things to understand before talking about 2 plus and 3 plus. Different places, it will be in different forms. Let's not go into that for now. Fine. Okay. Okay. Answer. It's a very simple question. The goal of the question is not to know the right answer. I want you to remember all the clues for most of the cancer syndrome. One or two combination, right? Patient presents the left flank pain, kidney, headache, weight loss. Also, there's a brain tumor here. Tumors are present. MRI shows a cerebellar mass, which is nothing but a cerebellar hemangioblastoma. So here, the combination is very significant. Von Hippel-Lindau can have clear cell RCC plus cerebellar hemangioblastomas, a very classical combination for von Hippel-Lindau syndrome, right? Okay, I'll give you the tumors in few organs. I want you to tell which cancer syndrome. Fine. If you have tumors in breast, sarcomas, leukemias, and gliomas, what syndrome? Tumors in breast, sarcomas, leukemias, gliomas. Which syndrome? That's your classical Li-Fraumeni syndrome, which might increase the breast cancer. The patient might have sarcoma. The patient might have leukemia. Almost every organ system affected here, right? The patient might have glioma. Li-Fraumeni is a mutation in TP53. P53 is the protein product. TP53 is a gene. Fine? Great. Patient having angiomyolipoma and cardiac rhabdomyoma and cortical tubers. Diagnosis? That's the next syndrome here. I'm writing AML. AML is angiomyolipoma of kidney, not your acute myeloid leukemia. Right? You can have cardiac rhabdomyomas. See, apart from this disease also has lots and lots of neurocutaneous manifestation. And you know that adenoma sebaceum, ash green patches, shaw green patches, ash leaf mark, multiple of them are there, right? Plus cortical tuber, you think of tuberous sclerosis. Fine, great. Neurofibromatosis, multiple neurofibroma, Lisch nodule. I can have schwannomas in few of them, schwannomas not in few of them, right? Optic gliomas and others, right? Neurofibromas, can have Lisch nodules, can have optic nerve gliomas, and schwannomas in second variant, not in first. Okay, these are these options, right? I'll give a few more clues. Tell me what cancer you think of. Patient with endometrial tumor, patient with colonic tumor. What all comes to your mind? There are two syndromes which has to come to his mind with this specific combination. Endometrial tumor, colonic tumor. Colonic cancer, endometrial cancer. Cowden-Lynch, perfect. Both of you answer, right? I'll add to this breast cancer. Breast colon endometrium is 1 and colon endometrium is 2nd. Along with colon endometrium, I'll also add to this renal pelvis cancer. BRCA1 will not have this, no? The first one, breast colon endometrium, is your P10 hematomatous syndrome or your Cowden syndrome. The second one, colon endometrium and renal pilus, your HNPCC or your methyl mismatch repair defect or your Lynch syndrome. Fine. The combinations are very, very important. If you miss them, you might miss the complete answer, right? Lots of colonic syndromes, please do remember them. This INST also had mutations and syndrome in the form of table. Anything can come. A very good source of MCQs, please don't forget them. Fine. Okay. Next. Simple. Let's see how many of you pick the answer. Tell me the answer, then I'll ask you a question. I want a very honest answer for the question. Okay, Sapna started with C. Sindhu has gone with bucket. Others. C, D, A, L, L. Okay, great. So most of you guys have commented. In the first question, please tell me an honest answer because this will determine how you're going to approach lymphomas and leukemias in future. Fine. When you saw this question, where did your eye go first? CD markers, yes or no? When you see a question like this or even this question, which did you focus first? CD markers, yes or no? If your answer to this is yes, the approach to lymphomas is wrong, you'll definitely make mistakes. CD marker is the last one for me to note. Please don't go with CD marker. You're missing the patient there, right? That's why you get problems in lymphoma. 12-year-old kid, there are only two things which can happen in children. One is ALL, second is Burkitt. Rest everything is in adults or adolescent group. Hodgkin's is an adolescent. DLBCL, mantle, everything is in adult. Age group, important. Cervical lymphadenopathy, okay to some extent, yes, but not most of the lymphomas will have overlapping finding. Only ALL and Burkitt are seen in children. So that will eliminate other two. Gone, no, it's very simple. TDT negative, not ALL. Because TDT is an immature lymphoid marker. It will be seen in every immature lymphoid blast. I can easily rule that out. I don't even want you to think of 5 and 23 here. Because 523 is a problem with mantle. It's not mantle. 12-year-old kid cannot have mantle. Or CLL. I don't have a problem at all, right? So not ALL, answer is Burkitt. Dissect the question. And please don't ignore the clinical presentation and the age. That's the first point of contact for me. CD markers are very, very essential. I'm not denying that. Solve like this, no? It becomes very simple. Just 2 points here. This tells me the answer. I don't even want you to know what is positive in Burkitt. Without that, we can easily solve them. Just few important findings, right? So for that, I'm going to give you few classical markers. Don't forget this at least. I don't want you to remember like 5-6 markers for one disease. That is a pathologist job, not an undergraduate job, right? Very simple things, right? TDT is for ALL. MPO is for AML. Without TDT and MPO, I cannot have ALL and AML. There can be variations, that's different. 90% of them will fall into this. MPO negative AML is like literally not there. It has to be there, right? Okay. NSC is for monocytic or a monocyte lineage. Okay. Non-specific estrase is for a monocytic lineage. Okay. 1920. Can you tell me, anyone tell me what marker is it? Simple ones. I'm going to ask you simple ones. CD3, what marker is it? 1920. That's for perfect B cell. CD3 is perfect T cell. So just one markers. So how do I say it's a B cell ALL? 19 positive, 20 positive, TDT positive. Please don't ask me is it pre-B, pro-B. That's not required for you. That's my job, not your job. T cell ALL. Child, mediastinum, then 3 positive, TDT positive. I don't look for TD3 first. Child, mediastinal mass, thymic mass, T for thymus. That's how I have to approach it. Fine. Okay. Now let's go for your cyclin D1. Which marker? Which tumor? CD5 positive. CD23 positive, which tumor? CMYC positive, which tumor? BCL2 positive, which tumor? ALK positive, which tumor? I'm not taking 1530, which we already know. Cyclin D1 is the marker I want for mantle cell lymphoma. Absolutely right. Okay. Write mantle like this. TL looks like 11, 11th chromosome. Translocation between 11 and 14. Obviously, you'll ask the next question. Cyclin D1 negative mantle is a PYQ SOX11. Not important at all. If the same PYQ repeats, important. Otherwise, not important, right? Next one, which is 5 positive and 23 positive. Perfect. 5 positive, 23 positive. I look for CLL. But tell me, which is more important for CLL? Marker or smudge cell? Which is more important for CLL? Marker or smudge cell? Smudge cell is more important. Lymphocytosis, adult lymphadenopathy, smudge cell, CLL. Marker to confirm. It will always remain Patel. Right? Marker to confirm, smudge cell is diagnostic of CLL. Smudge cell is enough. For an undergraduate, smudge cell is enough. Marker is not even required. See what is important for your level, right? MBBS student, if you know more than this, more than enough, right? CMYC. This is buckets. From now onwards, let's call it Burke 8. Simple, no? Translocation 8, 14. 14 is always common. Okay, 14 is always common for every lymphomas. 11, 14, 8, 14, 14, 18. It's Burke 8, 8, 14. BCL2, it's follicular, and follicular is 14, 18. Okay, can anyone tell me where do you see ALK? ALK. Let's see if you can tell the answer. ALK. ALK is not something which is very commonly asked, but I just want you to understand the concepts, the name of the genes, so life becomes very easy. ALK is seen in a condition called as, you're right, Bharat, lung adenocarcinoma. I'm looking for lymphomas. I'll think of an anaplastic large cell lymphoma. Fine. It's anaplastic large cell lymphoma or ALCL. ALCL has something called a hallmark cell. Okay, it looks like an embryo shaped cell, right? This is a hallmark cell or an embryo shaped nuclei. That's where ALK is positive. You know actually what does ALK stands for? Anaplastic lymphoma kinase. Seen in anaplastic large cell lymphoma. It's there the name. It is discovered there, that's all. It looks like an embryo or an hallmark, whatever you can, donut if you want to call it donut, fine? Okay, so these are just few markers, help you to easily say, this is positive, this is the answer, this is positive, this is the answer. In addition to this, you'll have clinical history, that's the first thing. Last markers, not first markers, right? So if you have a question with lymphoma, age, history, microscopic finding, last marker. Please don't jump to CD markers. You might make a mistake. A pathologist might be comfortable with the CD marker because every day when I see patients, cases, I'll open the book and I'll see. I'll be very honest. I don't memorize these markers. I need not. I need to apply the marker when it's required. That's all, right? So you also apply it whenever required. Fine? Answer. Great. Okay, guys, answer is you're right. You're absolutely right, right? Tell me, why did you say PML rara? What made you tell PML rara? What made you tell PML rara? Or AML M3? Is it this faggot cell? This cell with an abundant OR rod is a faggot cell. And faggot cells are classically seen in APML or an AML M3, right? Great, great. Super cervic. History, patience. I know it's an OR rod. OR rod can be seen in every AML. Why AML M3? Because this is a finding seen in AML. Run X, right? OR rod can be seen there also. Why not option C then? Diagnosis, raised PBT, elevated APTT, platelet count is less. There's only one AML which can present with DIC, which is APML. Microscopy, marker, or adjuvant, that's all. C is also an AML. So that's an add-on finding. That's also history with a microscopy or rod. Then I can say, yes, this patient is having APML. Correlate, please correlate. Otherwise, you'll keep making mistakes if I have a new question, right? Where do you see BCR-ABL? BCR-ABL is seen in classical CML, right? Can anyone tell me any other tumor apart from CML which can have the problems in BCR-ABL? BCR-ABL translocation can also be seen in, if CML is not then the option, ALL. Okay, you must have read that there's a different kilodalton weight. Primarily CML, ALL can also have BCR-ABL, right? Amazing, right? IgH, immunoglobulin H is there in your chromosome 14. Every lymphoma has its translocation, right? The chromosomal 14. It's a poor prognosis like marrow cell, right? Okay. This is a classical translocation seen in myeloma. Myeloma will also have chromosomal 14 translocation, fine? Sure, Srijan, just give me a second. See, there are very few point blank findings with respect to leukemias. ALL, the only thing which I want you to remember in ALL is, if it's a lymphadenopathy, think of a B cell ALL. If it's a thymus involvement or a mediastinal widening, think of a T cell ALL. Apart from that, it will be pancytopenia, non-specific findings. AML, again, very classical findings. When you see a DIC, I want to think of APML. When you see a gum hyperplasia, okay, when you say gum hyperplasia, I generally think of M4, M5, not just gum hyperplasia. When I see chloroma, I generally think of M4, M5. When I see leukemia cutis, I generally think of M4 and M5. When I see proptosis, I generally think of M4, M5. Okay, I'm not coming into the fight between M2 and M4, M5. I'll tell you the logic behind this. I'll tell you why it's just to be looked for. The M2 is a statistical problem. That is not a patient problem, right? Okay, now, what is M4, M5 unique for? That's a beautiful concept. Need not memorize this at all. I'll come to that, Gayatri. Like I said, M2 is a statistical problem. I'll come to it soon. What does M4, M5 mean? Let's understand leukemia. No, you'll never have this confusion of M2 or M4, M5. M4, M5 is monocyte. Super, right? Answer me this question. A neutrophil, can it go outside of the blood vessel without inflammation? Yes or no? Can a neutrophil exit a blood vessel without inflammation? It cannot. Can a RBC go outside of the blood vessel without inflammation or without trauma? It cannot. Can a eosinophil go? It cannot. Right, perfect. Can a monocyte go outside the blood vessel without inflammation? Can a monocyte go? Monocytes can go because monocytes are nothing but tissue macrophages, right? Perfect. Now, that's a property of monocyte, right? So let's say I'm having a monocytic leukemia. Can it go outside the bone marrow? Why am I even memorizing that? It can. It can go to my skin, leukemia cutis, extramedullary blast, chloroma, because monocyte can go outside. Normally also when they are neoplastic also. Proptosis, extramedullary, outside the blood vessel. Hyperplasia of the gum, not bleeding. Bleeding is a common finding. Hyperplasia, outside. Because monocyte has the capacity to go outside the blood vessel. Which means M4, M5 will have extramedullary involvement. That's all. There's no confusion between M2 and M5. There's nothing but extramedullary involvement. Extramedullary involvement will happen in this. No one can stop it. There's one more cell which can go outside. Can anyone tell me what other WBC can go outside normally? What other WBC can go outside normally? Can a basophil go outside normally? Basophils go and become tissue mast cells. Yes? Lymphocyte won't go. Lymphocyte will be inside hematolymphoid. Basophil can go. There's a basophilic leukemia also. That also will present with leukemia cutis. We don't teach you that because it's not very common. That's all. Fine. Basophil can go outside. These are two things I think when there's an extramedullary involvement. Now, why did M2 come into picture? This is screwed up entrance preparations problem. That's not science problem at all. If I take 100 cases of AML, just random statistics, 90 cases will be M2. Let's assume 5 cases will be M4. M4, M5 is 5 cases, let's assume. 100% of M4, M5 will have tissue involvement. But this, even if 10% is tissue involvement, what will be the number? 9. Even if 100% is only 5. That's a stupid question. I hope people will ask scientific questions and not idiotic questions like this, right? I hope when you guys become amazing professors, ask important questions. I want the junior doctors to be pillars of my healthcare, not memorizing this questions which comes for LKG student. 4 bananas, 2 apples, plus or minus. I'm not for that game. I'm for a scientific game, right? Gayatri, this is the reason why we got confused. It's simple reason. Macrophage can go outside, basophil can go outside normally. When there's a tumor also, it goes outside. That's all. That's why we have extramedullary involvement. I hope you will never forget that, right? So no confusion with chloroma, right? But if it's someone still irritating and asking is most common, go for AML-M2. Fine. Okay. So these are few clues. One more clue. Patient with myelofibrosis. Myelofibrosis will have splenomegaly. If there's a splenomegaly plus if it's an AML, wait, Nito, I'm not gone there, right? Think of an AML M7 because AML M7 is the only AML which can have myelofibrosis. Fine. There's a logic behind this also. Everything is logical. Since I'm in the PYQ session, I cannot explain you logics. Which is the largest cell in a bone marrow? Which is the largest cell in the bone marrow? Megakaryocyte? Yes, perfect. Bone marrow is a liquid, right? It's a blood flowing area. I have large cell. Imagine, let's assume megakaryocyte is like this. Okay, megakaryocyte is very big. It's like this. This cannot stay in the flowing place. So I need fibers to hold them. So imagine this becomes a cancer. What will happen to the fibers? Becomes big, more myelofibrosis. That's all. AML-M7 will have myelofibrosis. Polycythemia vera also will have bad megakaryocyte. That also will end up in myelofibrosis. Essential thrombocythemia will also have more megakaryocytes, will also end up in myelofibrosis. Whenever megakaryocytes is having a problem, they'll end up in fibrosis. Because for me, for normal megakaryocytes, I need fibers to hold because they're very huge. Becomes haywire, will have fibrosis by default. Fine. Okay, let's go to this. Guys are looking at the next question and answering. It's a very simple one, right? I'm not going to take much time in this. CD shows pan-acinar emphysema. Pan-acinar emphysema is classical for alpha-1 antitrypsin deficiencies, right? Okay. Please, after completing your exam, tell your juniors to learn concepts. MCQs are not really nothing, right? Great. Emphysema, there are only 3 types. One type which is not relevant clinically, we'll ignore that. That's a type called an irregular emphysema, clinically not relevant for me, right? So we have centri-acinar emphysema. We have pan-acinar emphysema. Not so common, we have distal acinar emphysema. Is it actually anatomical classification? This is acini, the terminal bronchial, respiratory bronchial, and acini. The center part of the acini is becoming big, it's centri-acinar. The entire acini is becoming big, it's pan-acinar. The distal part of the acini is becoming big, it's distal acinar. That's it. Mostly in upper lobe, smoking, and this is the most common subtype because smoking is undoubtedly most common, right? Pan-acinar. How do you identify pan-acinar? The most important thing is a patient will have history in the family because it's inherited. And there's an alpha-1 antitrypsin deficiency. This happens in lower lobes, more common than upper lobes. Can anyone tell me which is the other organ where it will be affected? Lower lobe or base, like Naman said. What's the other organ which will be affected in alpha-1 antitrypsin deficiency? Patient also will have liver failure. See, these are the different permutation combinations can happen. That's all. Liver failure, I think of a pan-acinar along with the lung problem, right? Distal acinar, also seen in smokers. Like someone said, he'll have pneumothorax, spontaneous pneumothorax or a tension pneumothorax, or it can also cause an bullous emphysema, and pneumothorax will be the symptom. It's an emergency, put an intercostal tube drainage, ask the person not to smoke, they'll not listen, they'll come back again with the same problem, right? That's dyslacernal emphysema, right? And, or paraseptal, whatever you want to call it, right? Irregular emphysema is there, which is seen a post-mortem finding. It's not clinically relevant, so let's ignore that for now, fine? Okay. Okay. Answer. Answer. Superb. Disease. It's a simple disease. The most important thing is the beautiful alignment of the question. A patient came to the OPD with a history of vomiting, diarrhea, and skin eruptions. Can anyone tell me what this is? Can anyone tell me what this is? That's your dermatitis herpetiformis. Okay. So dermatitis herpetiformis is a classical skin disease associated with celiac disease. Simple reason, this anti-TTG antibodies, no, this will cross-react with a protein in the skin. It cross-reacts and destroys the dermal folliculin. That's why I have dermatitis herpetiformis. Fine. Okay. History of similar episodes in the past. After switching to gluten-free diet, his symptoms resolved. One of the important things for us is your anti-tissue transglutaminase antibody. You can have anti-endomysial antibody. You can also have anti-gliadin antibodies. Fine. Few questions have been asked in celiac. Okay, I'm not coming to the most sensitive specific, Vivek. I'll leave it to the medicine person. Whatever is available in the lab, do it. That's more than enough. Fine. Because the difference in sensitivity specificity here is 2%. Not going to worry about 2%. And if it's like 60% to 100%, definitely worry about it. Fine. Okay. What is the HLA associated with celiac disease? The HLA which is associated with celiac disease. HLA DQ2 DQ8. Okay, this has been asked before, and I'm sure you know the bro foods. I'm not commenting on the bro foods. Your barley, rye, oats, and wheat, which are the one which is there. Avoid bro foods. That will help in celiac disease, right? If at all a microscopy is done, what will be the microscopic finding of celiac disease? If at all we do it, microscopic finding of celiac disease, we have villus atrophy. You'll have villus atrophy, and you'll have crypt hyperplasia. Crypt will become more because everything is being destroyed. It will compensate and produce hyperplasia. Both will be there in case of celiac disease, right? Okay, leave celiac. Other three options. Which disease? Antiparietal antibody. Which disease? I'm sure you will tell first answer is megaloblastic anemia, right? I don't want megaloblastic anemia. I want a chronic autoimmune gastritis where pernicious anemia is an outcome. It's an autoimmune gastritis first, right? Plus megaloblastic or pernicious anemia by default, right? Where do you see ANCA? ANCA is anti-neutrophilic cytoplasmic antibodies. The older terminology C-ANCA, P-ANCA is not used anymore, but still we'll stick to it. People will not change very fast. C-ANCA is your what ANCA? PR3 or MPO? C is your PR3 ANCA. We call it as of now PR3 ANCA, proteinase 3 ANCA, which is seen in vaginas. And P ANCA, the older terminology, we call them as MPO ANCA. We don't report it as P ANCA anymore. Okay. MPO ANCA is seen in your microscopic polyangiitis and your eosinophilic Shock-Strauss syndrome. Okay, it's being called as MPO and PR3 ANCA only. The report goes as MPO, PR3 ANCA. It is not called as C and P ANCA anymore. Fine. Okay. Now let's see how many of you can answer this. Where do you see this? Though not important, where do you see them? ASCA. ASCA stands for Anti-Saccharomyces cerevisiae antibodies. Amazing. IBD. Inflammatory bowel disease. Crohn's has an edge. Not much important. Crohn's, inflammatory bowel disease, you can see antibodies to Saccharomyces cerevisiae. It's a gut bacteria where I can have the antibodies, fine. Superb. Great. Diagnosis. Great. Flank pain, hematuria, histology shade of the patient is provided, clinical presentation and histological finding, which are the following conditions. The clear halo. Halo around the nucleus is diagnostic of an chromophobe RCC. That's all right. I'll give you simple terms to identify the different types of RCC. I'm not going to the part of plant nuclei. Might not always be much clear. I can have few cells like a plant. Few cells is mostly the uh, halo. Fine. Plant-like cell also, if you want, let's keep it, right? If you have very clear cell, the reason why I'm not calling about plant is plant cells will look very, very clear. You might confuse with clear cell RCC. When you see papillae and samoma body, it is papillary RCC. Okay. When I see halo around the nucleus, that's much more of a accurate description than a plant cell. But yes, if you want to write plant cell, let's go with plant cell, which call it chromophobe RCC. Okay. When I see only predominantly desmoplasia, desmoplasia is a predominant finding, like plus 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 plus. Think of an collecting duct Bellini RCC. Okay. Last but not the least, if we have papillae plus clear cells plus a young person, what's the diagnosis? Let's say 15, 20-year-old. You don't get RCC in 20-year-old, right? 20-year-old person having a renal cell carcinoma, microscopy shows both papillae as well as clear cell. Not medullary. There's a new, I'm sure you must have read this, XP11 translocation associated RCC, and the gene here is transcription factor E3 gene, TFE3 gene. That's a marker as well, right? Remember them, fine. Papillary plus clear, this is the most important clue. Young. We don't see RCC at 20 years old. If you see an RCC at 20 years old, is XP11 translocated as RCC without a doubt, fine. So these are few microscopic findings which can help you in terms of a renal cell carcinoma. Okay. Next guy. Like NASA had said, best prognosis of all is chromophobe RCC. It's a simple one, right? TTF1 positivity will actually give it away. 55-year-old chronic smoker, weight loss, hemoptysis, TTF1 positive. By default, the diagnosis adenocarcinoma. Lung cancers is something which is very important with respect to pathology. Also might have an overlapping finding if possible in your surgery as well, right? Let's have a see. Oncocytoma differences. Oncocytoma will not have the halo. Chromophobe RCC will have the halo, right? So an easy way to differentiate lung cancers. Okay. When a tumor is in the center of the lung, central tumor or the hilar lesion, mostly needs apna. You have cavity on an X-ray. You have calcemia, actually hypercalcemia. I'm just writing CCC so that's easy for you to remember. It is your squamous cell carcinoma, right? Perfect. Squamous cell carcinoma. Okay, small cell carcinomas might not be in the central lesion. They might a little bit go to the periphery, fine? Or it can happen anywhere. Peripheral, okay? Single lesion and ill-defined or infiltrative. Okay. Positive for your RAS mutation, KRAS, ALK mutation, and the common one in India, EGFR mutation, especially for Indians, that's your adenocarcinoma. Okay. Squamous cell carcinoma, microscopy will have keratin pearl. Can anyone tell me what is the marker for squamous cell carcinoma? I'm just dumping all the information here. So just before the exam, you can just see the slide. P63, P40. Both are good enough, but P40 is superior compared to P63, right? Adenocarcinoma, microscopy, you'll have glands plus invasion. And marker, both markers are good enough for me, TTF1 and napsin A. As a practicing pathologist, I will never call that one is superior or one is inferior. Always we apply both TTF1 and napsin A. Whichever works for the patient. That's all, right? So let's say I have glands plus no invasion. And there's one more specific pattern, lipidic pattern. What's the diagnosis? Glands, no invasion, and lipidic pattern. Diagnosis? This is again a very common question. Glands, lipidic pattern, no invasion. That's your adenocarcinoma in situ. In situ will have the no invasion, it will have the lipidic pattern, right? Please remember, don't use the term bronchogenic here. Bronchogenic is a very, very old term. We don't use it anymore. The older term for adenocarcinoma in situ is bronchiolo-alveolar carcinoma, but the new one is only adenocarcinoma in situ. Everything here will be subcategorized as bronchogenic carcinoma only, right? In situ and invasive, that's all. Fine. Okay. Now, endobronchial growth. This is a very, very classical one here, right? Endobronchial growth. It's a very characteristic finding of this tumor. Yellowish to orangish color tumor. It's a very, very, very low grade neoplasm. Okay. Microscopy will have nesting pattern or organoid pattern. What tumor I'm talking about? All these points to only one, which is carcinoid. Okay. Carcinoid will have all the features. Carcinoid jaw normally presses endobronchial. That's why you must have had the name. It might have a little bit of projection outside. Collar button lesion. Okay. It might destroy the bronchus and go outside. Carcinoid, collar button lesion, endobronchial, yellow in color, low grade. Low grade can never be a small cell carcinoma, right? Small cell carcinoma, the first and the foremost thing is it presents as paraneoplastic syndrome. See, Srijan, generally adenocarcinoma's paraneoplastic syndrome is very less. Small cell, yes. Squamous cell, yes. Okay. PNS, you can have SAADH or Cushing. This is very easy for me to create a clinical scenario question. That's the first thing. Fine. Site doesn't matter here. It can happen in any site. Fine. Smoking has to be there. This is like 99.99% present only in smokers. Without smokers, I won't have this at all. Fine. Okay. Microscopy, apart from the small cells, the most important thing is necrosis should be there by default, and your Azopardi effect. That takes your small cell carcinoma. Fine. Both small cell and carcinoid are both neuroendocrine tumors. Can anyone tell me one marker for neuroendocrine tumor? We'll move to the next question soon. One marker for neuroendocrine tumor. Let's add LEMS also if you want. Synaptophysin, chromogranin, CD57, bombesin. There are multiple of them. Synaptophysin, chromogranin, both of them will be positive. Remember this is positive for every neuroendocrine tumor in the body. And every neuroendocrine tumor, there's one more finding as well. Higher power we'll have, both of them will have salt and pepper chromatin. Okay, that also will be a common thing for every neuroendocrine tumor, right? NSC, neuron specific inlays also will be positive, right? So this covers almost everything required for your lung cancers. It's been asked in the previous few years, right? Okay, next. I'm not going to talk much about it, just only one variation. Diagnosis and the answer. You guys will master this, right? This is abdomen pain, hepatosplenomegaly, WBC more. So diagnosis, was it difficult? The classical case of CML. CML should be translocation 922. You become tired in 2 hours? Come on. Where's the Josh? Let's answer. CML diagnosis by default is translocation 922, right? Just one question. Same patient, okay? Same patient, abdomen pain, hepatosplenomegaly, WBC count of 2000. Hemoglobin, Nitu, let's leave that college girl, no? Let's leave the college girl alone. Hemoglobin of 9 gram percentage. Platelets of 25,000. Diagnosis. Sure, I also need some water. Diagnosis. Hemoglobin 9, WBC count of 2000, platelet of 25,000. Same history. Massosplenomegaly. Massosplenomegaly. In other words, whenever you have a patient with massosplenomegaly with pancytopenia, yes, obviously it's pancytopenia, diagnosis hairy cell leukemia. Because hairy cell leukemia clinically will mimic your CML, though it's very rare, it will mimic your CML. So you have pancytopenia with massosplenomegaly, it's hairy cell leukemia. You have leukocytosis with massosplenomegaly, go for CML. Fine. That's the only difference here. Hairy cell leukemia, you know that the cells are TRAP positive. I'm 100% sure you know the marker, annexin, A1 or B, whatever you want to call. Can anyone tell me what's a mutation in hairy cell leukemia? Mutation in case of hairy cell leukemia. That's your BRAF. BRAF V600E as a classical mutation in hairy cell leukemia. Please do remember, close to 100% of them will have BRAF mutation, right? BRAF will also be seen in papillary carcinoma thyroid. BRAF will also be seen in LCH. There are multiple tumors which can have BRAF mutation, right? Super, right? So clinically, easy to differentiate. Leukocytosis is one, pancytopenia is other, right? Can we have a 2 minutes break? I'll just go grab a water. You also go relax your legs and come back soon. Let's discuss about this more very soon. Fine, just 2 minutes. It's 8:07. I'll join by 8:10. We'll come back by 8:10. Fine. I'm not going anywhere. I'm just turning on my audio and video. That's all. Hey guys, welcome back. Doc Talks. Doc Talks. Okay. Uh, we'll have the class maybe. I have 16 more or 17 more questions. I'll try to wind it up by 9 because I don't want to waste your time as well. It's very precious for you rather than sitting in the class. Complete as soon as possible. Fine. Okay. Let's start. Fastest finger first. Pippin Sir fan club has answered the question. Which of the following is the most common mutation associated with the microscopic image of thyroid shown here? Answer? If you want, I'll zoom the microscopic image here. It's a very simple one, right? You can see the classical orphan Annie nuclei. This is molding of the nuclei, right? Look at this. This nucleus has been molded to this shape. There'll be molding, there'll be overlapping, and the classical clear appearance orphan Annie nuclei, which makes it your papillary carcinoma of thyroid. Papillary carcinoma of thyroid can show BRAF mutation by default. Fine, that's the right answer. You're absolutely right. Okay. Can anyone tell me which of the thyroid tumors will have RET gene mutation? RET. There are two things with RET. RET, PTC, translocation is seen in papillary carcinoma thyroid. RET mutation, like you guys said, you're absolutely right. It is seen in medullary carcinoma thyroid. MTC or MCT, whatever. Medullary thyroid cancer should have been a better one, right? Medullary thyroid cancer, fine. If it's a translocation, it's different. If it's a mutation, it's different, right? Can anyone tell me what is MET gene? Where do you see MET gene mutation? It can also be syndromic as a part of MEN2 syndrome. You're right, Gayatri. MET codes for a factor called as scatter factor. That's what is produced in MET gene. MET gene is seen in papillary RCC. Papillary renal cell carcinoma is where you see the MET gene. KRAS is seen in multiple things. You can see them in pancreas, you can see them in colon, you can see them in lung, multiple things you can see KRAS. Fine. Okay. Let's go to the next guy. Nothing much to read about this here. I should not highlight that not true, but still, answer. Which of the following is not true? B is not true. Let's see. Von Willebrand has the most common inheritance is autosomal dominant. Okay. The most common presentation of von Willebrand, most of the time questions also will have it, is menorrhagia. They present with menorrhagia, right? So we have von Willebrand 1, we have 2 and 3. 1 is the most common subtype. 1 will have less von Willebrand factor. 3 is the most severe subtype. 3 has 0 von Willebrand factor. 2 is qualitative. The amount of von Willebrand is normal. It will not bind with the glycoproteins. That's the problem here. In 2, it's a qualitative defect, right? So now with this, let's look at the options. Type 3 von Willebrand has severely low von Willebrand factor. Absolutely true. Type 1 von Willebrand is the most commonly seen in children. Von Willebrand is an autosomal dominant disease. When do you think autosomal dominant disease presents? It presents during adult life only. It will not be seen in children at all. Type 3 is recessive. Type 3 is very severe. 0 von Willebrand factor. They will present like hemophilia. That's right. Type 2 has moderate bleeding deficiency. Is qualitative, right? Remember, every autosomal dominant disease presents later in life only. The best example is your ADPKD, autosomal dominant polycystic kidney disease, right? It will always be present late in life. It will not be present early in life, right? So this is thing with von Willebrand factor. It's all pathology, Ragnar. It's just PYQs, randomly oriented in pathology. Fine. Okay. Tell me next. What's the answer? I'll zoom the image if you want. This is the image. Okay. So here the clinical history is little bit skewed, right? So I do have facial puffiness, I do have frothy urine. Frothy urine is equivalent to lipid in the urine and also hypertension. So where do you want to put nephrotic or nephritic or a mixture of nephrotic? It's kind of a mixture of nephrotic, like, but predominantly nephrotic, let's assume. Hepatitis B infection is there. Okay. Microscopy reveals hematuria. Again, I'm stuck between the both. Fine. It's having a little bit of both the presentation, right? I'll come to it, just give me a second. So if you look at this image, the membrane is extremely thick. It's definitely a thick glomerular capillary. It's not a normal glomerular capillary at all. It's definitely a thick capillary, right? So there's a classical presentation of membranous glomerulonephritis. To correlate that, this is an important silver stain finding in case of membranous glomerulonephritis. The stain called as Jones stain. Jones is a silver stain which is done here, and that is also seen in membranous glomerulonephritis. So the answer is option B, like you said. It's a classical patient of membranous glomerulonephritis. Doc talks it's not C. FSGS, you know that, right? So FSGS will have, if I have a glomerulus here, if half of them is completely gone or some of them is gone, this is how FSGS looks like. Okay. One more thing in glomerulus, if I have a pink nodule like this in glomerulus, always think of KW lesion. Where do you see KW lesion? We see KW lesion in diabetic glomerulosclerosis, right? Few things I'm telling it now, Sapna. When you have a glomerulus with capillaries there, but the mesangium is expanded, very big mesangium. Okay, capillary is still there. There's no nodule, just mesangium is bigger. Fine. When you have more mesangium, what do you think of? There's nothing but increased mesangium. You think of IgA nephropathy. Okay, you think of an IgA nephropathy, right? So FSGS, KW lesion, you have IgA nephropathy, and a thick membrane, you think of a membranous glomerulonephritis, right? These are few things I wanted to remember, and few clues. When there are more neutrophils in the glomeruli, increased inside the capillary, right? Think of your PSGN or PAGN. It will always be there, Jojo. Okay. And these are few clues which you can easily pick up with the help of an image. Okay, this is how this disease presents. Fine. Okay. IgA nephropathy will be more mesangium nessa. Okay. See, someone asked why later age group. In an autosomal dominant disease, how many alleles are mutated? Only one allele is mutated, right? When one copy is mutated, I call it autosomal dominant. In other words, one copy is normal. If one copy of the gene is normal, they might not present early. They will present late only. I have one half of the thing completely normal, right? So I'm not going to present early. I'll definitely present late. That's how in every autosomal dominant disease presents late in life, right? But recessive, both the copy are mutated, so obviously it'll present early in life, right? Okay. Answer? It's a simple one. A, B, C, or D. Simple, right? Patient with transfused 4 units 2 hours ago now has complaints of chest discomfort. On examination, she was afebrile, BP is elevated, X-ray shows bilateral fissural thickening. It's a classical finding of TACO or a fluid overload, right? This is always a confusion. Trally versus TACO. I'm not going with any hi-fi points. There's a big table if you go to transfusion medicine. I'm not going to that. I'm just going to go with very simple features. Trally is acute lung injury. Can I say it is like ARDS? It is ARDS, right? Will there be any ARDS without neutrophils? I won't. So can I say Trally will have fever? Yes. I'm just writing the differentiating point alone. TACO is a fluid overload. It's more fluid, will not have fever. There's more fluid in the body. So can I have hypertension? More fluid, same blood vessels, I'll have hypertension, right? There'll be increased BP. Here BP will be low. It's in a shock. It's an acute ARDS, everything is going to go off. BP will be low. Fine. Both will be within 6 hours. There's like BNP, atrial natriuretic peptide, all thing will be elevated here because of a heart problem. And the most important thing is this will become normal or at least symptom will improve with diuretics. Trally is an acute lung injury. Diuretics will not help. Crepitations both will be seen. Both will have lung problems. X-ray finding might be similar. Your CT finding also might be similar. But these are few classical flues for me to help. Trally, history of infarction or sepsis predisposes trally. Already there's an infection, easy to destroy my lung. TACO, history of cardiac failure predisposes TACO. Or a very old age person will predispose TACO, fine. But very important and very easy to differentiate. Low BP fever, trally. High BP, no fever, TACO. Circulatory overload and an infection here. That's all, fine. Okay, that's the easiest way. Age group is more or less same. It will not help us. Sorry, the time also is more or less same. Both of them happen within 6 hours of the transfusion. More or less same, will not help us. Fine. Okay. So this question is about TACO, hypertension, and afebrile, and just discomfort, fissure thickening. Everything is seen there. Fine. Okay. Next question. This is an extension of whatever we saw in your renal problems. Answer. These are all classical findings. Child, cola colored urine, that itself should give you the answer. Hypertension is there, so and so. Did not improve over next 3 weeks. Creatinine increased to 4.5. Right? There's one important thing. I'll come to that very soon. This child creatinine increased to 4.5 over 3 weeks. Will this qualify into RPGN? Yes or no? Okay, this is where I have lots of answers here. C, B, and A. Can I call this RPGN? Yes or no? Can I call this RPGN? 3 weeks? Okay. RPGN is rapidly progressive glomerulonephritis. 48 hours is my requirement. 3 weeks is very slow. Right? 3 weeks is not, I'm going to call it as an RPGN. Within a day or two, admitted in the ward, within a day or two, creatinine becomes twice or thrice of the baseline value. I can call it an RPGN. This is not an RPGN. It is becoming bad. It's not an RPGN, it's becoming bad first, right? So I have a child with a cola colored urine and hypertension, which is not improving, slowly deteriorating. So cola colored urine in a child, my first thought process is PSGN. I'll definitely think of PSGN, though I don't have any other findings such of PSGN or history such of PSGN, right? Not improving, that's all. I think of PSGN still. PSGN will have subepithelial deposit. To be very specific, it will have subepithelial hump-like deposit. That's very, very classical. If you see subepithelial humps, that's diagnostic of PSGN, because subepithelial deposit, just the deposit, can be seen in two conditions. One is PSGN and also in membranous glomerulonephritis. PSGN will have a hump-like deposit and membranous glomerulonephritis will have an uniform subepithelial deposit. If it's humps, it's PSGN. If it's uniform, it is membranous glomerulonephritis, right? Just one more history. Let's say a patient has an URI, upper respiratory infection. Post that, a patient had hematuria. Fine. But this was on the second day. This was after 2 weeks. Which is PSGN? Second day or 2 weeks? This also will be a very, very important history to help us differentiate the diseases. URI, second day hematuria, URI, 2 weeks hematuria, which is PSGN. This is PSGN. 2 weeks is PSGN. Second day is IgA nephropathy. Can anyone comment on the other name of IgA nephropathy? Other name? We have Berger disease. Right? Berger's disease, the other name for IgA nephropathy. It's immediate. It can happen post diarrhea, post URI, post UTI. Anywhere. Again, PSGN can happen post skin infection and post URI as well. Fine. Okay. Few clues clinically, few clues microscopy, few clues based on electron microscopy also. Fine. Super. Okay. This question, I don't know. I'm just taking it based on the recall. Whatever you guys gave, this may be a right recall, may not be a right recall as well. Because if something changes in this question, the answer will change. Child presents intermittent jaundice, splenomegaly. There's a history of similar complaints in the elder brother. Peripheral smear shows this finding. What's the next step? How will you investigate this condition? First thing, this is the finding. NASA HSP is a systemic disease. When I have vasculitis in the skin, lower buttock, in the lung, in the kidney, it's HSP. IgA nephropathy is also an HSP, but only in the kidney. That's the only difference. Like Goodpasture syndrome involving lungs and kidney was anti-GBM glomerulonephritis involving only the kidney. Fine. Okay. These are spherocytes. Smaller, darker cells, no central pallor. Okay. Smaller, darker, no central pallor, I'll think of a spherocyte. Spherocyte is the most common finding you'll see in every hemolytic anemia. Whenever there's hemolysis, you'll see spherocytes, not just in spherocytosis. Fine. Okay. And this is a normal RBC for your comparison, will have a central pallor. So the only thing here is child and the family history. The family history is there. I think of an osmotic fragility test and hereditary spherocytosis only because of the family history, right? Now let's assume, and also I have splenomegaly to corroborate my finding that it's not happening due to acute cause, it's happening for some time. Fine, that's why this. So otherwise, if there's a child or an adult, when you have spherocytes, what's the first diagnosis you'll think of? The first diagnosis, what's the first diagnosis? Someone commented as well. Child or an adult, spherocyte with no family history, with no splenomegaly, my first diagnosis is always autoimmune hemolytic anemia because it's the most common cause. If that's so, what's the next step? The next step will be Coombs test, right? So if the question changes, your answer changes. Don't blindly follow this. This is what will get repeated. It might not. Be it a child or be it an adult, if there's no family history, I'll still think of an autoimmune hemolytic anemia because penicillin can cause it. We can give penicillin to a child also, penicillin to an adult also, right? So there are lots of conditions which can cause autoimmune reaction. The first is obviously autoimmune hemolytic anemia. Do a Coombs test. But with the family history, with a splenomegaly, which says it's a little bit chronic, I can go for a spherocytosis. Fine. No. HS is an autosomal dominant disorder. They present later in life. HS, the most common mutation is ankyrin. Okay. Autosomal dominant presents later in life. HS can also be due to spectrin defect. Spectrin related HS is autosomal recessive. They can present during children. Okay. It has both. That's why you mostly they'll present later in life only, but there's a possibility it can also present early in life. Fine. Okay, Srijan. Okay. This we already discussed, so I'm just going to tell the answer and move to the next one. What's the answer? Renu, indirect Coombs test is done in only one condition. Clinically relevant condition for you, which is your RH incompatibility for the mother. Fine. It's a simple one. Asbestosis. 20 years. Mesothelioma. There's only one guy, which is asbestosis. Fine. Okay. Perfect. Next. Rest everything is going to be direct Coombs test only. I didn't give the image. I missed the image. I should have given the image, but I'll write the image here. Image shows smudge cells. You can still identify or tell without smudge cells. Still, I gave a help. It's simple, right? Flow cytometry. Actually, without the image also, I can easily narrow it down. Elderly male, lymphocytes elevation, marked leukocytosis. I think of a CLL. CLL, I think of a flow cytometry, right? Now, there's leukemia and lymphoma. We have ALL, we have AML, we have CLL, and we have CML. And then CML. For all these three, investigation of choice is undoubtedly flow cytometry. I'm just going to ask you a question. I want you to answer yes or no. Bone marrow is essential or must for ALL, AML, CLL, and ALL. Yes or no? Do I need to do bone marrow examination? Yes or no? The answer is no. I can do flow cytometry on peripheral smear. CLL, peripheral smear. AML has more blast, peripheral smear. ALL is also peripheral smear. Bone marrow is not must. Bone marrow examination is not at all required for any of them to diagnose. If I don't have enough blast in peripheral smear, then I go for bone marrow. Otherwise, flow can be done on peripheral smear blood. CML, flow cytometry is not the investigation of choice. Like Bharat said, I go for either fish, obviously the best option. Not there, I go for karyotyping, or even better than that, if you have PCR. Real-time reverse transcriptase PCR would be the ideal. PCR, fish, or karyotyping will be the best option for CML. Again, I cannot do flow cytometry. Again, same. Doesn't require bone marrow examination at all. None of the leukemia require bone marrow examination or diagnosis if peripheral smear has enough blast. Fine? Okay. Perfect. Next guy. Srijan, starting point is flow cytometry. I might require fish for AML to prove what translocation I'm seeing. But starting point by default is flow cytometry. For subcategorization, I might require fish. Or to prognosticate, I might require fish. Right? Simple clinical scenario, young patient, large retroperitoneal hemorrhage, intermittent swelling in the knees, almost always think of a coagulation disorder. Okay. I'll obviously think of factor 8 and factor 9 because hemophilia classically presents with an hemarthrosis and large intraperitoneal hemorrhages. That's the first option I'll think of, right? So you have two types of disorder. One is a bleeding disorder. One's a coagulation disorder. How do you think bleeding disorders will present? Like thrombocytopenia, dengue fever. How do you think bleeding disorder will present? Bleeding disorders always present with petechiae and purpura. You must have seen patients with dengue, petechiae, purpura. Coagulation disorders always they present with deep-seated bleeding, like a hemarthrosis or in the retroperitoneum. It's always deep-seated bleeding for coagulation disorders, right? There's one classical history which will help me to differentiate bleeding or coagulation. Listen carefully and answer. A patient had a trauma, or I'm cutting my finger. It kept on bleeding. Continuous bleeding after trauma, first. Second, I cut my finger. It bled, stopped. After 5-6 minutes, start to bleed again. Which of these two will you think will have re-bleeding and which will have continuous bleeding after trauma? If there's a history of bleeding after trauma continuously, bleeding or coagulation, re-bleeding where you will see. Re-bleeding is always a finding seen in coagulation disorder. It stopped, it started again. It's a coagulation disorder. Fine. Continuous bleeding is a bleeding disorder. I'll give you why as an example. See, clot has two steps. The first step is a temporary clot, then is a permanent clot. Temporary clot is made by platelets. Without this temporary clot, permanent clot cannot form. So if there's no platelets, temporary clot cannot form, permanent clot cannot form, keeps on bleeding continuous. These are platelet disorders. Primarily, the problem is platelets. But in a coagulation disorder, platelets are good. So the clot will form, but it cannot be reinforced by coagulation factors. So bleed stops, but this is temporary, right? Dissolves, rebleeds again. These are clotting. As the name says, there's a problem in the clotting factors. So clinically, I can differentiate this. Might not help in an exam, but definitely will help in real life to tell where I'm going to investigate for. Fine. Okay. Next. That's what is required, Jojo, right? Facts, no, please don't go behind facts. ChatGPT will eat us. Let's explain, let's analyze so the ChatGPT will not eat us. Elderly male, known smoker, chronic cough, weight loss. Okay. This is the clue here. Clues are stuck between the questions, right? That's small squamous cell carcinoma, right? Hypercalcemia, elderly male, weight loss, chronic cough can be common for anything. Again, large atypical cell hyperchromasia, large neuroendocrine tumors also will fit, but hypercalcemia is a classical paraneoplastic syndrome seen in case of squamous cell carcinoma. We already seen the table of entire lung cancers. Read that when possible. Okay, next question. Yes, Bharat. Hmm. Great, we are having mixed response, osteosarcoma and giant cell tumor. Super. I think most of you must have, some of you who are told giant cell tumor. Is the problem that it's looking close to the epiphysis? Is that your concern? Is that why you answer giant cell tumor? If so, we are approaching bone tumors wrongly. Bone tumors have a classical approach. The first and the foremost thing in bone tumors, look at the age. That's the first thing. Age is of very important. A 10-year-old will not have giant cell tumor, will not have chondrosarcoma, will not have these. Osteoblastoma may not, but definitely not the other. That 10-year-old alone is enough for me to call it osteosarcoma. I obviously think of an osteosarcoma in a 10-year-old. Children. That's very important for us to diagnose bone tumors. So bone tumors, any question in bone tumors you have, the order of importance should be this: age, location, epiphysis, metaphysis, diaphysis, X-ray, radiological finding, then if required, histopathology and markers. Actually, with the first three, no, you'll be able to answer it. You'll be definitely be able to answer it. Histopathology is just for confirmation. Post surgery, I'll have that. That's all. Fine. Okay. Yeah. Now let's see how it is osteosarcoma. Giant cell tumor. Can anyone tell me whether it's benign, borderline, or malignant? GCT, or an old name of osteoclastoma. Benign or malignant? Giant cell tumor is a benign and is a locally aggressive tumor. Okay. Giant cell tumor is a very benign and a locally aggressive tumor. Giant cell tumor is extremely hemorrhagic. It will locally erode. That's why you have the soap bubble appearance. Soap bubble, entire inner aspect of the soap is being destroyed, right? That's why it's like a bubble. It's locally erosive. It's not a malignant tumor at all. If you remember treatment, you don't cut the limb. You curate and put a bone cement. Why am I going to curate for a malignant tumor? Malignant tumor, we amputate, right? Here, we take the cavity, put a bone cement and seal it. That's how we treat generally. Fine? Perfect. And age group. Age group is 20 to 40 years. It's epiphyseal. It's expansile. Right? That's how it is. Fine? That's the normal age group for giant cell tumor. Right? Now let's look at this image. It's an amputation specimen. That's the first thing. Second, if you carefully look, we can explain all the features what you must have read. Can I say this is the bone cortex? Can I appreciate the bone cortex? The lines I am drawing. Now, can I tell that this tumor is going outside the bone cortex? It's breaching the bone cortex. This also is a tumor. Yes. Destroying the bony cortex is making it malignant. So it cannot be a giant cell tumor. It cannot be definitely an osteoblastoma, which is benign. It has to be an osteosarcoma, right? So now the tumor is destroying and going outside. Will it lift the periosteum? It must have definitely lifted the periosteum. If it lifts the periosteum, what's the finding? You might have the, if I have the X-ray, you might have the Codman's triangle. Definitely will happen, right? Gayatri said one more appearance, sunburst. Why am I having sunburst? Osteosarcoma is a bone-forming tumor. So wherever it's invading, wherever it's going to the tissue, it will form calcification, right? It's a bone-forming tumor. So sunburst appearance is nothing but a soft tissue calcification. which is suggestive of invasion. That's all. The soft tissue calcification due to invasion is giving the sunburst calcification, which is also seen in case of an osteosarcoma. Fine. Okay, that's how it is. If I have to redo this question and say, what is the genetic change you will see in this patient? Can anyone tell me the genetic change? One common gene, if you know, that's enough, but I'll add one more point as well. What's a common genetic change you will see in this tumor? That's RB mutation. If you say this, I'll be more than happy. Right? But there's one classical or a very unique finding which you see in osteosarcomas, chromothripsis. Chromothripsis is seen in osteosarcoma, which makes the prognosis very poor. Chromothripsis, chromosome, it will break. Entire 46 chromosome will break and will reignite in different parts. 1922 itself is causing a problem, right? So it reignites in different parts. That's very difficult. The chromosome breaks all throughout the genome and it reunites, causing multiple translocation, which is going to be very difficult for the patient to survive. Fine. Okay. Great. Next question. Yes, the shattered chromosome like what NASA has is an absolutely right example. Comment on the answer. I'm sure you know the answer. I just want you to tell why. Serum ferritin, I will not. Okay, now let's look at the image first. Fine. Can I call this microcytic hypochromic anemia? It's microcytic. It's definitely hypochromic, right? Microcytic, I don't have a lymphocyte to compare, right? Now, can anyone tell me what are these cells? The cytoplasm looks like an RBC, but there's a nucleus, right? That's your NRBC. The cytoplasm is looking like an RBC and the nucleus is there. That's an NRBC. Okay. Nucleated RBC, whenever you see NRBC in any question in any image, this is a severe hemolytic anemia. Could be an alpha thal major or a beta thal major. That's all. It cannot be a minor. It might not be an intermediate also. It has to be a thal major. First thought is thal major, or it could be a full-blown sickle cell anemia also. It's a severe hemolytic anemia. That's all. That's what the correlation is, right? Now, 18-month-old kid brought to the clinic with a history of fatigue. Parents give a history of repeated transfusion. Peripheral smear of the kid is given below. Which of the following is the best to diagnose? Parents' HPLC will not help me to tell what the kid is having. Parents has a problem, but the kid might not have the same problem. If there's a kid's HPLC, great for me. Parents' HPLC will not help me. Bone marrow is not required for hemolytic anemia. Serum ferritin is not required now. Maybe when I give a transfusion later on, it might help me to look for secondary hemosiderosis, not now. The best answer is globin gene study. For alpha thal, the best test is globin gene study, because globin gene study can help me to identify every part of alpha thalassemia. And there are 4 different types of alpha thalassemia. Globin gene can help in everything. Few of them, yes, I can do diagnosis peripheral smear, but investigation is that. Beta thalassemia, investigation of choices, HPLC, but HPLC of the patient, not the parent. I need HPLC of the patient, not the parent. That's why my option is option A. But if the option B has been patient's HPLC, I'll go for that. I'll definitely go for that as the answer. But since it's parent's HPLC, it will not help us at all. Fine. Okay. Next one. Just few more questions. I think I might have 5-6 questions. We'll be done soon. "40-year-old history of recurrent infections, bleeding gums, examination, investigation pancytopenia, peripheral blood shows macrocytes, bone marrow shows no macrocytes, filled with fat globules, your diagnosis." I want more guys to answer. Come on. A, or until now we have A and B as the answer. Till now we have A and B as the answer. Fine. Let's take all the required things here. We have macrocytes, okay, and bone marrow biopsy shows fat globules. Can I say this fat globules in the bone marrow biopsy are replaced by fat as an hypoproliferative finding? Definitely, right? Obviously, this makes it hypoproliferative. I'm not calling it aplastic, it's hypoproliferative by default, right? Now, PNH will not be hypoproliferative. We just now saw when we discussed PNH, it will be in cellular or in hypercellular bone marrow. I'm not going to look for TB also. There's no granuloma, no TB. That's all, fine? So there are two guys here. It could be an MDS or it could be an aplastic anemia. Both of them are possible. Both of them can fit into the clinical history. Both of them actually can fit into the biopsy also because I have something called hypoplastic MDS. But what does MDS stand for? Myelodysplastic syndrome. Without dysplasia, I cannot call it an MDS. I need documented dysplasia, right? So there is no dysplasia in this question. I don't have dysplasia, and macrocyte alone is not enough for me to call it dysplastic, right? I need to have dysplasia in the bone marrow, should have had something, right? When there's no dysplasia, I cannot call it an MDS. So I am going to prefer an aplastic anemia. Please rule out. Ruling out helps you easy way to answer the questions. Fine. That's very, very important because it's myelodysplasia. Fine. You need to have dysplasia to call it a myelodysplasia. Clinical scenario questions are the easiest. The same way you sat in an OPD and you saw the patient. That's all. Analyze and evolve. Fine. Bharat, I wouldn't say so. There are hypoplastic variants of MDS also. But yes, MDS generally might have a little bit of more cellularity. But MDS need not always have more cellularity because MDS classical presentation is cytopenia. So it should be low cellular only. Fine. Let's come to this. When this question came, there's a huge hue and cry about the question. What it is the B12 deficiency or a folate deficiency, right? Very simple ways to differentiate B12 and folate. You won't have a problem in calling it an megaloblastic anemia because MCV of 115. Only megaloblastic could be the possibility, right? So I have to find how to differentiate B12 or folate, fine? B12, there's only one, vegan, not vegetarian. Vegetarian does not cause B12. Veganism causes B12. No milk, no animal protein can result in B12. Here, no greens, no fruits. No greens and no fruits makes it folate. The simple reason is folate is there in milk. Folate is there in meat. But folate is a heat level vitamin. If you cook, it will destroy. You won't eat a meat without cooking nor drink a milk without cooking, right? Without pasteurizing or without boiling, right? That's why greens and fruits are required. I don't heat a fruit, we'll eat it. Greens, lettuce, I don't heat them, we eat it, right? That's why it's required. So if there's no fruits and greens, folate will become deficient. And obviously, like you guys are saying, the neuropathy, the neurological manifestation by default will help me to say it's a B12 deficiency. And finally, I need to have the B12 and folate levels to say whether it's B12 or folate. That's all right. These are two important things for me to identify as B12 or folate. Rest everything will be normal. Both will be macrocytic. Both will be megaloblastic. Both will have hypersegmented and neutrophil, right? One question which is asked in AIMS exam. In case of an only B12 deficiency, what's the treatment? Isolated B12 deficiency, what's the treatment? Will I give only B12 or will I give both B12 and folate? Only B12, both B12 and folate. You have to give only B12. It's an isolated B12 deficiency. Give only B12. Don't give both B12 and folate because there's a problem if you give both B12 and folate. You'll have worsening of neurological features. B12 and folate both giving was an old way of approach. You have to give only B12. Please don't give both B12 and folate. And as a classical example, lack of fruits, vegetables to go for folate deficiency here. Fine. It will precipitate and it will make the neurological manifestation severe or worsen if you give both. Fine. Okay. Next. These are a little bit older questions, somewhere in 1920, I think so. Young adult pap smear was evaluated. Microscopic examination showed pleomorphism, hyperplasia, cells involving all the layers of epidermis with disordered growth. Pleomorphism, no, no. These are only two possibilities. Rule out. Involving all layers of epidermis with disordered growth. Only this, because here I need invasion. Only if invasion is there, I'll call it a carcinoma. Otherwise, I cannot call it a carcinoma. If you want to name this finding in microscope, what will you call it? All layers of epidermis showing pleomorphism hyperchromasia. Can I call it carcinoma in situ or your older CAN3? I can, right? I need to have a breach of basement membrane or invasion to call it a carcinoma. Since it's not there, I'd prefer dysplasia as the answer. Probably a carcinoma in situ or a CAN3. Fine. That's how this is. Actually, this explanation is a biopsy explanation. It's not a pap smear explanation. Pap smear might not have layers of epidermis. Fine. Okay. Again, an extrapolation of CML. CML seems to be a very favorite topic amongst NEET PG exams, right? 3 years or 4 years exam, 2 to 3 times CML has been repeated, but in different ways. What's the answer? So classical case of CML, we have discussed this already. Lab score, clinical relevance is 0. No one actually does lab score. Only people who are crying about lab score is when we prepare for entrance exam. You go for an MD path or an MD medicine, you'll not even hear about that, right? FISH, PCR for BCR-ABL is the definitive diagnosis. Massively enlarged spleen and shift to left. By default, I'm going to think of a BCR-ABL thing. Immunophenotyping will not help for CML. That's why flow cytometry is not required for CML. Fine. Okay, next. 40-year-old person, such of cirrhosis, liver biopsy was performed. Can anyone tell me what this is? Intracellular deposit of keratin was found, cytokeratin was found in liver biopsy. This is nothing but your Mallory hyaline, the older Mallory hyaline, or an Mallory Denk bodies. Fine. So Mallory hyaline or Mallory Denk bodies, it's nothing but destroyed cytokeratin 8 and cytokeratin 18. If you have to ask the number, this is what it is. Fine. Two more things, Nitu. I'll complete it for sure. Okay. It's actually destroyed or damaged or ubiquitinized cytokeratin 8 or 18. Right? That's a classical finding of mallory model. And obviously, cytokeratin is an intermediate filament. Actin, microtubules, and intermediate filament, these are 3 intrastructural proteins. And cytokeratin, your Wymentin, everything come under intermediate filament. Fine. Okay. Just 2 more questions, Nitu. We'll be done with it. And these were very simple questions as well. Don't ask me if there's a third question. I think there are 2 more questions. Answer? Okay. Interesting. I thought it's a very simple question. We are having different answers here. HNPCC or a Lynch syndrome is a methyl mismatch repair, right? It's not a base section repair. Can anyone tell me what's a syndrome when you have a nucleotide exchange repair? Nucleotide exchange repair mechanism, what syndrome will have? You'll have xeroderma pigmentosa. Okay, that's a nucleotide exchange repair. Non-homologous end joining. Any gene which is involved in NHEJ, non-homologous end joining, that's also a type of repair. Any genes? With respect to cancer, Fanconi is one good thing with respect to cancer. Okay, Fanconi, yes, I'll consider Fanconi. Fanconi's fan complex, it's actually related to BRCA. BRCA is also a part of Fanconi's fan complex. That's why if you remember, BRCA2 can also have Fanconi anemia, right? Yes, do remember that, right? BRCA, if it's like solid cancer related to BRCA, BRCA1 as well as BRCA2 is involved in non-homologous and joining repair, fine? Right. This is the last one, as right in saying two. This also had lots of confusion when that year NEET PG recall happened, because some people said it's benzene, some said it's benzidine. Answer? Again, we have the same problem B and A. See, this is the problem, right? Okay. Which tumor do you think benzene will cause? Which tumor do you think benzene will cause? Benzene causes leukemias? You accept that, right? Benzene causes leukemia. Which tumors will benzidine or aniline dyes causes? Which tumor does it cause? It causes bladder cancers, right? Perfect. See, these are facts. The examiner is making it an easy exam, but we students are making it a difficult exam. Why am I worried about benzene or benzidine? If it's a history, right? If it's a history of bladder cancer, what will be the symptom? Fatigue, infection, or hematuria? No, no, don't worry about D being bladder. That's a very, very, very irrelevant conversation here. I don't want you to even remember that. You're a doctor. Why I want you to go and read chemistry? I don't want you to read chemistry. Patience, plus with hematuria. This is irrelevant for me when there's an history. If there's no history, yes, the D helps, double D helps, everything helps. When there's a history, look at the patient. Patient presenting with fatigue. Can I say it's because of anemia? Yes. Multiple infections because of reduced WBC, which is where it is fitting into a blood cancer or a bladder cancer. It's fitting more into a leukemia, right? That's all. When it's a scenario-based question, solve the scenario. Don't go with one fact you know and try to fit everything into the fact. It's a patient. Patient cannot be determined or solved with facts. Scenario-based question cannot be solved with facts. It has to be interlinked, come to an answer. If it had been a bladder cancer, and if it's whatever it is, beryllium, whatever it is, I don't want beryllium and lung cancer. Hemoptysis, cough, chronic smoking, I'll think of that. Right? When this exams become scenario based, you are at an undue advantage. Please use them, right? Please don't go back to fact and read facts. Fact in this time is not required at all. Fine. Okay, that's all for today. Need to, right? I completed before 9. I get 2 more minutes before 9. Fine. Okay. I just taken like last 4 to 5 year questions, compiled and removed the repetitive topic and kept the rest. I hope you enjoy the session. And if there's any doubts, put in the comment box here. I'll try to reply there, or ping me on Instagram. I'll try to reply there as well. Fine. All the best. Do well. You will have every day 111 subject for PYQ, and stay tuned. And definitely you'll do well. I have trust in you. You also have trust in yourself. Fine. Okay. Thank you, everyone. Thanks a lot. Bye bye. And I'll give the PDF immediately. It will go to your Telegram channel of PW. The Telegram channel should be in the comment section, or it should be in the description of the video. Fine.